بالتالي for the short of time we start last session in this interesting committee. واحنا هنتكلم this session about the acute coronary syndrome in COVID-19 patient, conserve or intervene. I share this session with chairperson Dr. Mohamed Al-Ghani, associate professor of cardiology in CardioAssiut, Dr. Mohamed Abou Qasim, associate professor of cardiology in CardioAssiut, okay, and Dr. Professor Khalid Shukri, military, and the president of Egyptian Society of Cardiology, Professor Islam Shawqi, professor of cardiology in Azhar, and Dr. Sharaf Eddin Shazli, associate professor of cardiology Sohag. We start this session and عندما يبقى ايه دكتور علي بس في المحاضرات مش بس اوكي. We welcome Dr. Ali Farghali. It is one of candidate of CardioAssiut and one of the person from CardioAssiut University, and now he is in America. We start session by Dr. Shuru Kilani. He will speak about introduction of case of COVID and acute coronary syndrome.
Assalamu alaikum. I will introduce two cases of acute coronary syndrome in COVID-19. Okay. It's my pleasure to introduce two cases of acute coronary syndrome in COVID-19 patients. First case. Case number 1, male patient, 51 years old, not known to be diabetic nor hypertensive, but known to be smoker and addict. Patient had history of fever, 38.5, and dry cough. He presented to our ER complaining of typical chest pain of 1 hour duration. On admission, patient arrested ventricular fibrillation. DC and CPR was done for 10 minutes. Then he was put in mechanical ventilation. After stabilization, pulse was 110 beat per minute, regular average equal with palpable pulsations. Blood pressure was 100/70 millimeter mercury, respiratory was 30 breaths per minute, and temperature was 37.5. Cardiac examination showed no unremarkable changes. ECG showed sinus tachycardia, raised ST segment from V2 to V6 and inferior leads, with depressed ST segment in 1 and AVL. Patient had CBC, which showed lymphopenia, and the previous CT, which showed bilateral ground glass opacity. So the decision was to intervene or manage medically with thrombolytic therapy. That will be discussed later. Case number 2, male patient, 45 years old, not known to be diabetic nor hypertensive, but smoker. Patient had history of active COVID-19 2 weeks before admission, and he underwent home isolation, received treatment according to the national protocols, but currently on no treatment, and he hasn't undergone a second swab to prove that he was negative. He presented by typical chest pain of 4 hours duration. Pulse was 80 beats per minute, regular, blood pressure 110/70, respiratory rate was 16, and temperature was 36. ECG showed raised ST segment from V1 to V6, and 1 AVL and inferior leads. So we decided to do laboratory investigations to decide whether it is perimyocarditis or ST segment elevation, myocardial infarction. Cardiac troponin was 12 nanogram per milliliter, and the echocardiography showed hypokinesia in the apical cap with normal LV ejection fraction. So the question now was, is it perimyocarditis or ST segment elevation myocardial infarction? Thank you. Thank you.
Thank you, Shiro. for these two cases. It's my pleasure. We start with, it's my pleasure to introduce my friend, Dr. Ali Ahmed, one of one of the Assiut University sons. Now he is director of imaging center in Toledo University. Welcome, Dr. Ali.
Thank you, sir. I appreciate being here. Thank you, Dr. Hassan, for the invitation. And it's great to see my friends, colleague, and mentors, Dr. Muhammad Abul Qasim, Dr. Muhammad Abdul Ghani, Dr. Amr Youssef, and Dr. Islam Shawqi. They are all friends, Dr. Ahmed Abul Wafa and Dr. Khalid Shukri and Dr. Adel Atribi. I will start without further ado because I have a long presentation. It's a complicated topic with the imaging in COVID patient. And honestly, we're being consulted on almost about 90% of the patient admitted to the hospital with COVID. And as you know, we have over 100,000 admissions across the United States.
Dr. Ali, share your presentation.
Sure, yeah, I'm sharing, I'm starting the presentation.
We just have your photo, but slides not yet.
Yeah, so I will start with, as we said, we have over 100,000 admission of COVID-19 patients across the country, and we're being basically consulted for almost 90% of the patients we see in the hospital. So we have three basic concepts on evaluation of patients COVID-19. Number one is you follow systematic approach. Basically, patients with COVID-19 or no COVID-19 should be treated the same. So we start with history, physical examination, blood test, EKG, and an imaging modality, whether this can be as simple as a chest X-ray, and it can be as complicated as, coronary angiography and PCI. This is not enough in COVID-19 patients because basically there is a lot of overlap in symptoms between COVID and cardiac patients. So this is the first concept we actually teach the fellows during evaluation of COVID-19 patients being admitted to the hospital. The second concept is why it's challenging. It's challenging because there is a lot of overlap in symptoms, as we said before. Number one, dyspnea and chest discomfort are very common in those patients. Number two, there are frequently abnormal chest X-ray and pre-natriuretic peptide and elevated troponin in those patients. And then when it comes to the imaging, we have to have the imaging interpreted and requested based on the local expertise. So if you don't have a good cardiac CT lab, then there is no point of ordering a cardiac CT. If you don't have a good cardiac MRI lab, then there is no point of going in this direction. And we're gonna go in the next few slides to see how we tweak our imaging protocols. Actually, there were a lot of updates and local policies from the institution and from the state which imaging modality we do and which imaging we should not proceed for. Concept number three is protection of the staff and contain the spread of infection. This is essential because, we use imaging labs not only for COVID patients. We're not shutting our imaging labs for non-COVID patients. So we have a very big mission here to basically disinfect the imaging room and also disinfect the imaging machine and also protect the staff. Number two, we have to spread the infection. We have to do the imaging only if it will change management. So that will lead to how we guide our imaging for those COVID-19 patients, and not every patient should have every single test on earth. So we usually start, as I said, history, complete history, physical examination, and biomarkers. And the biomarkers we use a lot are basically general chemistry. And the most important part of this is we do lactate, and actually the computer if we have what we call sepsis protocol. So if you have an elevated lactate and the above 2, then the computer will generate an automatic order to order a follow-up lactate level in 2 hours. So, and it would have what we call a hard stop, meaning the physician has to address before leaving the patient chart on the computer that he understands that this is happening and I'm still assessing, and you cannot go anywhere. You cannot get out of the chart without be acknowledging that you saw the result. From the cell count, we use leukocytosis and lymphopenia are a big deal. And in patients who are like not really kind of septic, we use ferritin level, CRP, and interleukin-6 and procalcitonin. Procalcitonin is very sensitive and highly specific, and even before it will be elevated before the lactate level. The dimer is essential because of the known association of the thromboembolic disease with COVID-19. And here is our major part, which is a cardiac biomarker. This is the most common cause of cardiac consultation in COVID-19, which is elevated BNP or elevated troponin level. And here, it's universally elevated, to be honest, and for different reasons. We're going to get through it in the next few slides. But what the more important is the trend of these cardiac biomarkers. So if we use the 5th generation high sensitivity troponin, and if this remains stable, then you can say, okay, fine, I'll continue medical management. But if you have, symptoms and signs and EKG changes and troponin that support ACS, we still take those patients to the cath lab. So there is a very nice paper in the JACC Imaging in September. I think it's ahead of print though, but there are 4 clinical scenarios where physicians are being consulted for, cardiologists being consulted for evaluation of COVID-19 patient. And this is the first reason, and I saw the 2 cases, which are actually very interesting to me. And I may have to answer a couple of these questions that they left open up, which is really great to start with. So the most common cause of consultation are chest pain and abnormal EKG in a hemodynamically stable patient. So we get, this patient has a chest discomfort, some minor EKG changes, nothing to call this acute coronary syndrome. And the evaluations are, differential diagnosis are a lot. As you see, they have, multifocal pneumonia. They can have myocarditis, pericarditis. They can have pulmonary embolism. They can have a stress-induced cardiomyopathy, which it seems to me the second case was presented actually was apical cap hypokinesis and a hypernormal left ventricle. It can be stress-induced cardiomyopathy, and also it can be secondary to myocardial injury, either from hypoxemia or from the tachycardia, and it can be acute coronary syndrome. So we have multiple causes of chest discomfort and abnormal EKG in patients with COVID-19. And how we approach this, it's our first step. It always start with history and physical examination. Second is followed by EKG, and the third is followed by the biomarkers, as you said, basic chemistry, DMB, cardiac enzymes, lymphocytic counts, D-dimer, lactate level, and one form of imaging modality may be enough. Maybe we need more. So you can start with a chest X-ray or your point-of-care echocardiography, which we use this a lot nowadays in COVID-19 patients just because of the time-sensitive information we need, and also to minimize contact with those patients and contain the spread of the infection. So we always start with the point-of-care ultrasound or a full transthoracic echo. We're using more honestly of the CT angiograms and CT coronary angiography. Basically, if you're getting to the pulmonary artery, you're getting more information about pulmonary embolism and bilateral pulmonary infiltrate. We're using a CTA a lot in these patients. It's based on the ischemia trial. Just make sure they have no left main disease, no proximal LAD disease, and then you can manage medically, unless if they have a definite acute coronary syndrome. And again, the biomarkers will guide us through this part. So this is the first scenario we do. And here's a simple protocol from this exact same paper in the JAG. If you have acute coronary syndrome and STEMI, there is no choice. We go for the cardiac cath lab no matter what. We take our PPE and we protect the patient as well, and disinfect the cath lab room and all these kinds of routine work we do. If you have equivocal symptoms here, you will start with point of care ultrasound or a full CE, and if you have regional emotional abnormality consistent with acute coronary syndrome, then we proceed with either CTA angiography, which it got a step up actually in the protocol for imaging during this COVID-19 pandemic versus coronary angiography. Or if you have non-CED and some equivocal symptoms, we're going to go for a stress testing, and I will tell you later how we changed our choice of the stress test based on the COVID-19 pandemic. The second scenario here is which is the most drained one, hemodynamic instability, shock, or hypotension. As you see, this is just require a quick action. Etiology is also very wide, and it can be an RV or LV dysfunction, and this with or without myocarditis, with or without myocardial injury. We have a well-known syndrome which we call sepsis-induced cardiomyopathy. There is a myocardial depressant factor circulating in the blood, and it actually decreases the LV function and RV function in those patients. It can be a pericardial effusion tamponade. It can be, once you put the patient on the vent with a high PEEP, you have a significant drop in the blood pressure. And this is kind of interesting, which actually relates to this second case or the first case that's presented. Cardiac arrest is present as a first sign of COVID-19, even without respiratory symptoms. I'll come to this part later on. So as you see here, the protocol is simple, but it's more aggressive. So we start with our 5-point evaluation, never miss clinical examination, EKG, biomarkers, chest X-ray, and then we go for a point-of-care ultrasound or a full transthoracic echo. If you have pericardial effusion, you need to deal with this. Valvular abnormality, you need to deal with this. RV dysfunction, you look at PE. We do CTA gated with for the pulmonary arteries. And this is even more prevalent though. You have patients who have chronic right ventricular failure from chronic lung disease, pulmonary hypertension, and now they got an infection and they got extremely decompensated. Then you do have to do right and left heart catheterization for this. If you have an LV dysfunction, you have to differentiate by a simple imaging modality whether you suspect this is a non-ischemic cardiomyopathy or it's an acute coronary syndrome. If you have an acute coronary syndrome, no choice, going for the cardiac cath. But actually, they recommend no further imaging. If you do a point-of-care ultrasound, you have a regional emotional abnormality consistent with coronary artery disease territory, you take the patient for the cath lab, no further imaging. Imaging will delay intervention, and imaging will spread the infection. Imaging will expose the staff basically for the infection with the COVID-19. So, but if you have a decent echo with dilated left ventricle, global hypokinesis, biventricular failure, then you can think about non-ischemic cardiomyopathy, whether it's a tachycardia-induced cardiomyopathy, sepsis-related. You can have the cytokine-mediated cardiomyopathy, or even a previously known idiopathic cardiomyopathy or infiltrative cardiomyopathy, as we know. The third scenario is this new LV dysfunction, and it's common. You get we're not, most of the time we're not consulted for this unless the patient start with an echo that admitting physician or the lung doctors order an echo, and you incidentally find left ventricular dysfunction, and this can be either from before ischemic or non-ischemic cardiomyopathy. It can be an acute coronary syndrome. It can be fulminant myocarditis and stress-induced cardiomyopathy, which is cytokine-mediated, as we know, and tachycardia-induced cardiomyopathy or other forms of cardiomyopathy that is pre-existing from these patients. And again, the protocol is simple. Start with point of care ultrasound, start with the 5-point evaluation, history, physical examination, EKG, biomarker, simple imaging modality, which is most of the time a point of care ultrasound or a full dedicated transthoracic echo. And you differentiate between ischemic or non-ischemic cardiomyopathy. This is kind of loose if you can find dilated left ventricle with global hypokinesis, thinning, it's probably non-ischemic cardiomyopathy. Or if you have, the full wall thickness with regional wall motion abnormality, this is an acute coronary syndrome. We don't take a chance. Those guys are going to the cath lab, no further imaging. So the fourth scenario, which is kind of interesting to know, which could subacute or chronic phase, and there are different etiology for it. Number one, we give those patients tons of fluid to maintain their blood pressure. They are septic, so they're they have extravasation of the fluid. They needed the fluid, and then they can go in heart failure from fluid overload. They can have a pre-existing cardiomyopathy, and they got decompensated from the management or from the tachycardia or from the stress of the procedure of the sepsis and the disease. They got decompensated from putting them on a vent, and they can have progressive ischemic heart disease, and we're going to come to this point because this is the most interesting part of it. They can have myocarditis, pericarditis, or thromboembolic disease. This is a nice graph, though. So in the acute phase, we are dealing with all these kind of we have elevated troponin, sometimes cardiogenic shock, and sometimes we have just non-specific ST segment changes and chest pain, and most of the etiology we discussed before. So later on in the phase of the subacute, we get the heart failure stuff, and this is very interesting to me, worsening of the coronary artery disease and microvascular dysfunction, and we predicted here it's years. Why we think this will happen? Because in 2002, when the SARS came, there are a lot of patients have worsening left ventricular function and worsening coronary artery disease and worsening cardiomyopathy. So honestly, we know this disease is going to stay with us. Even if we have a vaccine, even if the pandemic is over, those patients with chronic heart disease, they will still suffer from the sequelae of this disease if they got infected. So we have to, this is just, a prediction, and we think this prediction is real. Then how we changed our imaging modalities with those patients or over the pandemic period of time. So number one is we have to make sure the patient and staff are safe. We do use our imaging labs for patients with non-COVID, so we don't want to give them the infection. We have to maintain our staff, and you know how critical the shortage of the staff has been in the United States. In fact, this year I did not, I have 5 weeks of vacation. I took only 1 week and a couple of days here and there, just because we're being so busy. Then we have this, the aerosol generating procedures versus non-aerosol generating procedures, and it changed our testing modality, as I'll get to this part. Well, most of the procedure has to be done in a negative pressure room, so we used to do the TE anywhere. Once you have the team and the anesthesia team and then the staff and the respiratory therapist, we can do the TE anywhere. But now we actually dedicated a negative pressure room for transesophageal echo because it's a huge aerosol generating procedure. And in fact, we're doing it only if it's absolutely needed, and it's only if it will change the management. We changed our stress testing modality. We'd love to do a treadmill MyView stress test and a treadmill exercise stress echo. We changed those ones to pharmacological stress, and for 2 reasons. Number one, the patient can use the mask throughout the procedure, and they are not aerosol generating. We consider it less risky to the staff, and so we change it. We just like basically give up the exercise data, which is very important just to get a good imaging data rather than the exercise part. And then with the most important part, we avoid layering of multiple imaging procedures because, you know, if it's not going to change the management of the patient, just don't do it. This did not result in lower or fewer number of imaging. It actually resulted in because of the volume of the patients, we're busier than ever. This is a busy slide, but it will give you an idea how we changed our imaging modality here. Cardiac CT is very easy to disinfect the room. It's very quick. There is minimal patient contact with the patient. So if you are imaging patient with no COVID symptoms, you need surgical mask and gloves. If you suspect COVID, you need surgical mask, face shield, gown, and gloves. And the same apply for the MRI. Problem with the MRI is the length of the acquisition. We don't do that much, although it's only single test that can give you the most information you need. Again, pharmacological stress testing, we consider this non-aerosol generating procedures. So we consider this droplet and contact precautions only. So we use surgical mask and gloves for non-COVID patient. We use surgical mask, face shield, gloves, and gown for suspected or confirmed COVID patients. Transthoracic echo with a pharmacological stress, it's probably the same, but there is more close contact with the patient. So you need to have more of a face shield and even with our COVID patients, confirmed or non-confirmed. The exercise stress test, as I said before, we change those ones to pharmacological stress test because we don't consider those one aerosol generating procedures. The use of TE has declined a lot during this pandemic, and basically because it's a huge and it's aerosol generating procedure. It has to be done in a negative pressure room. And we actually shifted most of these if you have an other imaging modality that can give you the same information you're looking for. We avoid transesophageal echo, including even pre-cardioversion ones, as I will come in the next slide. So based on these facts, as I said, we switched pharmacological stress test, giving up the exercise data, and we did pharmacological stress test more than exercise stress test. And confirmed patients and suspected patients, you don't have to. In non-COVID patients, we don't have to, providing that the room is disinfected prior having a patient from, outside patients from coming just for an imaging. TEs and CT scan are changed a lot during this period of time, and I'll come to this part. And again, avoid layering of imaging, only do it when it changed management. So I'll go quickly through some of these considerations. CMR is great. It gives you a lot of information about ischemia, thrombus, myocarditis, pericarditis. You can do a focus scan in 30 minutes, and there's minimal staff to patient contact. You just put the patient inside the room and just get imaged. But honestly, we don't do it a lot in COVID-19 pandemic just because it's a lengthy procedure. This infection of the room and the machine is very lengthy procedure. I mean, it's like you have to do a lot of work to make sure the room is clean. So if you don't need it, don't go for it. Myocarditis and pericarditis can be diagnosed clinically, can be diagnosed with an echo, can be diagnosed with the biomarkers. So if it will not going to change the management, don't go for it. So there's a huge decline in cardiac CMR during the COVID-19 pandemic. There is actually an upgrade for cardiac CT, mainly because it's a quick, rapid test, minimal patient contact, and then you can get what we call, you can evaluate multiple territories here. You can look at, if you get to the pulmonary artery, you can rule out pulmonary embolism, and at the same time, you look at the lung field, confirm this by multifocal pneumonia, and you look at the pericardial effusion, pleural effusion. If you're doing it to rule out acute coronary syndrome, the main rule is to rule out high-risk anatomy, which, as we know, coming from the ischemia trial, just make sure there is no left main disease, no major proximal LAD disease. And then if the patient has, significant distal disease here or there, and if you can manage medically and the clinical scenario does not support acute coronary syndrome, you go for it. So there is an upgrade for cardiac CT. There is a downgrade for cardiac MRI during COVID-19 pandemic. We even used cardiac CT now to identify left atrial appendage thrombus before cardioversion to avoid TE. So there is really downgrade for TE and upgrade for cardiac CT. All you need is to do a first pass, and then you do a 6-second delayed imaging. And even vegetations can be seen if you have a good cardiac CT reader. And that's why we have to have a choice of the imaging modality has to be guided by the local expertise of the institution. This is a slide, but this is the highlight of the study here. And as I said, the TE has a lot of downgrades. So basically, you see these X's here and there. It's still the gold standard, though, for intracardiac vegetations. I mean, if you suspect infective endocarditis, you have to go for TE. Yes, you have to, and then you take your precautions, put your patient in a negative pressure room. Some of us actually start using a full face coverage with a hole in it, so you can just basically get the probe through the throat of the patient, and then use anesthesia so they will not struggle and they're not a lot of aerosol generating. Although still we suction them throughout the procedure, so it is still aerosol generating procedure, and it's still a high risk for spread of infection. Then there are more rule of the echo and point of care ultrasound, because these are easy, quick, give you a lot of information, and it will guide therapy. Here's my last slide, and I hope I did not go over the time though. We use imaging carefully. You don't have, it's changed a lot, and we changed actually the protocols a lot during this pandemic. Early in April, we shut down all elective procedures, and of course they open up again, and now we cannot do it anymore. So we have more procedures done because there are more sick patients that need to be imaged. But the choice of the imaging has changed, and it mainly guided by the institution policy and the state guidelines. Some of the states are more liberal, some of the states are more strict, and also to mention, just it's kind of amazing that the state of Ohio passed that bill that say, we're providing partial immunity for physicians to decline procedures, even if they are like kind of questionable need for it. Of course, we're not doing this just because of the liability problem. Still, the litigations are draining and lengthy procedure. But my point is, every institution kept changing the guidelines for the imaging and the management based on the prevalence of the disease and the number of patients admitted and the need for procedures. This is my last slide. Thank you so much, and I'm willing to take any question.
Thank you, Dr. Ali, for this comprehensive presentation. Of course, we have a lot of questions, but first we'd like to welcome Dr. Shadi Rais, Director of Interventional Cardiology Research on Detroit, Michigan, USA. He is with us, and the first question comes from Dr. Hussam Hassan.
I think you are here because Muhammad, we are in the panel. Okay, don't mute me again. If you are going to mute me, I'm gonna leave. Dr. Hussam.
Dr. Islam Shawqi.
Yes.
Start, Dr. Hussam, your question, please.
Yes, yes, Dr. Muhammad. Yes, Dr. Hussam.
دكتور اسلام كنت
You are the
Okay.
Of course, we
I would like to thank
we have the pleasure to be with us,
Dr.
Dr. Islam.
And I would like
One
to
of
thank
the
also I would like to thank also the chairman online, Dr. Khalid Shukri, and Dr. Adil Kiri, and some others I don't know. I am very proud to hear Dr. Ali Ahmed today. It's a great lecture, Dr. Ali. Thank you very much. I'm wishing you and the family the best of health and luck. This is a very comprehensive talk, and you mentioned all the data I want to hear in this very, very comprehensive lecture. The very important message you give today, that there is upgrading for CT indications. We are not only taking care of patients with low to moderate risk. Now we can image apart from STEMI and the non-STEMI patients, any patients with chest pain, even those having high probability, they can do cardiac CT to exclude patients with left main and proximal LAD. Thank you, Dr. Ali, and thank you, Hussam, for invitation, and I am done.
Okay.
Islam Shawqi, thank you so much. We're friends, and I'm proud of being friend of you, and honestly proud of my staff and colleagues and professors in Egypt. And you know, I will. It's really a pleasure to be here, and I'll do as much as I can, and I hope I can help in any way. I really appreciate your nice work. Thank you so much.
Thank you.
I have a question to Dr. Ali.
Yes.
In your presentation, you mentioned that the advantage of CT, that you can have a CT image of the coronaries, of the pulmonary arteries, and of the chest at the same time. You know that the image acquisition requires different timing for the pulmonary arteries than the coronary arteries, and for the chest. So when you are planning to do CT for all the three, which is your plan regarding the timing of contrast injection and the timing of image acquisition, and which you will do first in acquisition? In the, if you are planning to do it in the same imaging acquisition setting, or you do it by several times of contrast injection?
Well, thank you, Dr. Hassan. I think I did not explain this point very well. So it's mainly, again, we start with clinical examination. We start with a point of care echo or a full dedicated transthoracic echo. And you're right, we cannot image everything at the same session. We actually, we can target our gating to the pulmonary artery to look at pulmonary embolism. And at the same, the lung does not need any gating, so you can see the bilateral infiltrate, and you see the pericardial effusion, pleural effusion, and the pulmonary embolism. But for coronary CTA, you have to have a different study. You have to gate your contrast acquisition and into the coronary arteries. We also use a different maximum intensity projection and different slicing. So coronary CTA is different than pulmonary embolism protocol. So we cannot image everything at the same setting. We have to have two different separate tests for this, but this is all guided by clinical examination, biomarkers, point of care echo, and what we are actually looking for. Thank you so much for that question. That's great.
Okay, Dr. Ali, let me comment on this. Because sometimes we have a fast machines, and if you have a region of interest into aorta, and you can get a very excellent coronary image, and if you having in your mind some question about the pulmonary artery, you may still see the pulmonary for the large pulmonary embolism, main pulmonary artery, or main branches, I think.
I totally agree. Yes, we sometimes do, but you know what? I think it is just maybe it's my country here that's causing this problem, because because of the liability problem, we always say the study was not designed to the pulmonary artery. Although the proximal pulmonary artery has no pulmonary embolism, I cannot rule out pulmonary embolism in some of these cases. So I totally agree, and I look at the studies, and we do a lot of post-imaging processing, 3D acquisition, and volume rendered images. Yes, you can tell, and sometimes actually pulmonary embolism is a frequent incidental finding, even if you're imaging the coronary arteries. So I totally agree, but most of the time, honestly, it is just, I think it's mainly for liability problem. We would like to have 2 separate studies if you need to, and again, it will only need it if we will change management.
Okay, thank you, Professor Ali, for excellent and elegant lecture. One of the interesting slide is slide about the type of the test and the possibility of infection and how to protect for each test. I think it is very important to be applied even in our institute. Yeah, it is very interesting for me. I want to conclude your lecture. I think I understand that the first step is clinical ECG and cardiac enzyme. Second step, if needed, rapid echo, and second step is CT.
This applies to most of the cases. I will take this exception only in patients coming with cardiogenic shock. If they are hypotensive and they are kind of like, now at this point there is no reservation for what we can do. So if they are they are on 2 pressors and their RV function, LV function is bad, then we have to go for a full. There is no really limitation for any imaging protocols. If you find pericardial effusion, you don't do phosphentesis, you go for it. If you find acute coronary syndrome, take the patient to the cath lab. This is the only case when you have a cardiogenic shock. There is no resolution because now the death from cardiac cause or from sepsis is much higher than death from COVID-19 infection. But all other scenarios where like you have equivocal symptoms and you have equivocal EKG changes, minimally elevated enzymes, minimally elevated BNB, now you're absolutely right. We take the clinical examination, point of care ultrasound, or even transthoracic echo, and there's an upgrade for cardiac CT, and there is a downgrade for TE and CMR. This basically the main modification we have done through the COVID-19 pandemic.
Thanks, Dr. Ali, for this informative lecture, which discuss different scenario for COVID-19 and cardiovascular disease and the role of imaging modalities in these scenarios. Thank you very much.
Thank you, guys. I mean, I enjoyed seeing you. You're all my friends, and I'm lucky I have 2 home countries.
Staying with us, Dr. Ali, for a lot of questions waiting you. We have also with us Dr. Khalid Shukri, the president of Egyptian Society of Cardiology. Dr. Khalid, Professor Khalid.
I see he's muted.
We need to hear his comment on this case, if it is possible. Okay, we can shift to the next speaker.
I have the pleasure to invite Professor Sameh Shaheen, Professor of Cardiology at Ain Shams University and the past President of Egyptian Society of Cardiology. He will address cardiovascular consequences of COVID-19, highlights from the Egyptian national consensus. Professor Sameh.
بسم الله الرحمن الرحيم. بشكر أستاذ دكتور حسام حسن واسم القلب في أسيوط كله على الدعوة الكريمة للاشتراك في هذا المؤتمر الناجح اللي أصبح ليه شكل وليه تواجد مميز على خريطة المؤتمرات العلمية لأقسام القلب في مصر. My topic today is about the cardiovascular consequences of COVID-19, and I'm going to refer to highlights from the Egyptian national consensus. At a very early stage in the pandemic of COVID-19 in Egypt, we realized how serious the condition is. And the Egyptian Society of Cardiology published this rapid guide to be as a guide to Egyptian cardiologists to the management of cardiac patients during the COVID-19 pandemic. And this was the position statement of the Egyptian Society of Cardiology paper. As I mentioned, it was clear from the very beginning of this pandemic how frequent is the cardiovascular disease as a comorbidity to COVID-19 patients. And of course, the prevalence was highest at the oldest age. So if the patient is above 65 years old, then he has a 50% chance of having a comorbidity of cardiovascular disease during the COVID-19 infection. At younger ages, the comorbidity is still there, but to a lesser extent. And again, it should be mentioned that as early as March in this year, it was published in a clear data that cardiovascular disease comorbidity is associated with the highest mortality among COVID-19 patients. If the patient is having an associated cardiovascular disease, the mortality rate will be almost 10.5% among COVID-19 patients. And other comorbidity, again, has a serious effect on the prognosis of COVID-19 patients. To make it most simple, a cardiologist can meet one of these three possible scenarios during the COVID-19 pandemic. First, he might meet one of the cardiac patients who developed COVID-19 infection. So this is a previously known cardiac patient with whatever diagnosis, but he developed COVID-19 infection. So this is the first scenario. The second scenario is a patient with COVID-19 with no previous history of cardiac disease. But during the course of the COVID-19 infection, he developed cardiac complication. So again, this is another scenario in which a cardiologist might be involved. The third scenario is a patient with uncertain diagnosis, like a patient presenting with chest pain or shortness of breath, with a possible diagnosis of cardiac or COVID-19 complications. So he might be either a cardiac or a COVID-19. Still, this patient is undiagnosed. Again, this is a possible scenario in which a cardiologist might be involved. So these are the possible cardiac complications that might develop in a COVID-19 patient. This patient might develop an exacerbation of a previous cardiac problem, or he might have acute heart failure with no previous history of heart failure before, so this is an acute de novo heart failure, or an acute myocarditis with all the manifestations of myocarditis, or an acute coronary syndrome, whether it's an ST elevation or ST depression, acute coronary syndrome. Again, this might be a presentation during the COVID-19, or an acute stent thrombosis, or a DVT, venous thromboembolism, DVT and pulmonary embolism, or he might present with any type of arrhythmias. Particularly, I've seen patients with atrial fibrillation as the presenting manifestations of COVID-19, or he might present with a Takotsubo-like syndrome with apical ballooning and depressed ejection fraction and ST elevation, or he might have a serious side effect of the COVID-19 treatment. So again, these are the possible acute presentations of patients with COVID-19 in which a cardiologist might be facing and might be involved in. So In patients presenting with myocardial injury during the COVID-19 infection, what are the possible mechanisms that might lead to myocardial injury and myocardial damage in these scenarios? The first is the typical type 1 myocardial infarction with rupture of one of the plaques in the coronaries, presenting with ST elevation MI. So this might lead to myocardial injury through this classical presentation. And this scenario is not uncommon. The second scenario is oxygen supply versus demand mismatch. This is type 2 myocardial infarction. Because of the hypoxia, because of the hypotension, this patient will develop sort of a mismatch between the oxygen supply and the demand, so the patient develops a type 2 myocardial infarction. And again, this is another possible mechanism of myocardial injury. In a third scenario, this might be due to direct viral cardiomyocyte toxicity, and we'll be talking about this in a while. So this is a possible scenario to have myocarditis due to direct viral invasion of the myocardium. Or the problem is not in the epicardial coronaries, it is in the microvasculature because of this microthrombi or because of vascular endothelial dysfunction. This might lead to, again, to myocardial injury because of microvascular obstruction and dysfunction. So this is, again, a possible scenario. Or, as I've mentioned before, a patient might present with Takotsubo-like syndrome, with ST elevation, with apical ballooning, with severe left ventricular dysfunction, with normal coronaries. Or this might be due to the hyperinflammatory state or the hyperinflammatory storm in which this antigen-antibody reaction might lead to myocardial injury. And we have learned from many publications that the hypersensitivity cardiac troponin is a good tool to assess, first to diagnose the presence of myocardial injury and to assess the prognosis of the patient. The higher the hypersensitivity troponin, the worse is the prognosis of the patients. And you can see in this paper how much is the difference between non-survivors in red, in which there is a high level of cardiac troponin along the course of the infection versus compared to the survivors who had very low levels of high sensitivity cardiac troponins. The second tool that proved to be very helpful in the diagnosis and in assessing the prognosis of patients with COVID-19 is the D-dimers. And again, you can appreciate the difference between the non-survivors' high level of D-dimers versus in green versus the lower level of D-dimers in the survivors. So again, this might be a good tool to assess whether the patient is having any form of thrombosis and whether his prognosis is serious according to the finding of a very high level of D-dimer during his investigations. But all the previously described manifestations were acute manifestations during the acute phase of COVID-19 infection, the acute cardiac manifestations. But now we are starting to realize that we might have long-term effect of the COVID-19 on the cardiac patient or on the myocardium. And this was a paper published in the last summer, and it proved by autopsy studies that there are viral invasion that was present within the myocardium in such patients. So they started to think about the long-term consequences of this cardiac involvement. So this was the first time to prove that there is a direct invasion of the virus to the myocardium, and that this might have serious long-term implications on this cardiac patients. This is another very important paper that again was published in last summer. This paper examined 100 patients with recent recovery from COVID-19. So these patients got full recovery from the COVID-19, and during the assessment of these patients with MRI, they found that 60% of these patients had still ongoing myocardial inflammation in terms of late enhancement gadolinium in this study. And this presence of ongoing long-term myocardial inflammation was independent of the pre-existing condition of the COVID-19 infection, independent of the severity of this disease, and independent of the overall course of the acute illness, or the time from the original diagnosis, whether this follow-up was early or late after recovery, but they have the common feature of being all fully recovered from this infection, yet they are having signs and showing signs of persistent ongoing myocardial inflammation in 60% of the specimen examined. And again, it raised questions about the long-term cardiovascular consequences of COVID-19 infection. And this is how they proved that MRI might be a very useful tool in assessing the residual myocarditis in some of the patients after recovery from the acute illness. And they can here show us that these patients might show this late enhancement of gadolinium in the myocardium and in the pericardium sometimes. So these are patients with proved long-term myocarditis after recovery from COVID-19 infection. And actually, this paper in the USA made a lot of disturbance in the media because it was about professional athletes. They studied 26 professional athletes, and this is, again, a common story in our country among Egyptian soccer players. 26 of these professional athletes in the United States got examined after full recovery from the COVID-19, and 4 of these professional athletes, that's 15%, had elevated T2 signal of late gadolinium enhancement consistent with myocarditis. And this was a true surprise to most of those dealing with the professional competition in the USA, because it has serious medico-legal responsibility whether to allow these patients to return to their competitive sports activity, whether there is any serious side effects like arrhythmias or something like this that might happen to these sort of healthy subjects after full recovery from the COVID-19. And by the way, all of these patients had a very mild COVID-19 infection with no ECG or troponin abnormalities and with left ventricular function that was normal. So yet, despite all this, 15% of these athletes showed signs of myocarditis. So this was a great problem in the USA, and I think it can be also correlated to our condition in Egypt or in any other country. And the question was whether we allow routine screenings post-COVID-19 infections to detect cardiovascular damage, whether this should be routine to thousands and millions of patients recovering from COVID-19, even if they are asymptomatic, even if they had a mild course of the infection, Up to this moment, I think that we don't know how to deal with such a problem, with such a high incidence of chronic myocarditis in these patients. And actually, it was the American College of Cardiology, and after this, a letter from 50 medical professionals, they concluded that this does not imply that CMR should be performed in all COVID-19 positive patients to screen for myocardial inflammation. It's not yet high time to use routine CMR to detect chronic inflammation or myocardial inflammation in such patients. And actually, they asked in this letter to discourage the use of cardiac MRIs on asymptomatic people who test positive for COVID-19. We still need more data to recommend this as a routine follow-up study for all patients with COVID-19 infection. And this is my take-home message, that cardiovascular comorbidity are common among patients with COVID-19. As you have seen, that it might reach to 50% with cardiovascular comorbidity among elderly patients, and that COVID-19 infection can manifest as acute cardiac complications in many patients with different scenarios, and that long-term ongoing myocardial inflammation has been reported in a good percentage of asymptomatic recovered patients, but it's still unclear how to early detect and screen those patients and how to manage. Thank you very much for your attention.
Thank you very much for excellent lecture as usual, Professor Sameh. My only comment is the importance of the point of myocarditis or asymptomatic myocarditis, because many players, like even Muhammad Salah, after infection with COVID, he go to play in competitive player 2 weeks later, and we know if it's a suspect of myocarditis, we must stay 3 to 6 months away from competitive sports. So it is very important point must be searched later on. We go to the next session. Next speaker, Professor Chadi Rais, which is the Director of Intervention Cardiology Research of Detroit Medical Center in Michigan, USA. He will speak about the management of acute coronary syndrome in COVID patients. Start, Professor Chadi.
Good morning. Can you hear me? Good morning. Can you hear me?
Yeah, you can start, Dr. Chadi.
Okay, thank you so much. Thank you for the invitation, and really it's a big privilege to be here among legends in cardiology. It is my first time speaking to Egyptian physicians, but I have to say I learned a lot outside the US and in the US from all the publication, the work that you have done, and the patient care that you provide. Thank you so much for the opportunity. The topic that was assigned to me is management of patients with COVID-19 and acute coronary syndrome. So I'm going to highlight a few things that already I think covered by Professor Ali Ahmed and the other speakers. Some overlap, but also will share our experience as well. These are my disclosures. As we know, the myocardial injury with COVID-19 happens in 20 to 30 patients of COVID patients, but the most important point is that the case fatality rate has the highest in patients with cardiovascular disease, especially in patients who has established coronary artery disease or they are unknown heart disease before. When they get infected, the chances of having increased mortality is compared to other comorbidities is much higher. And the mechanism covered extensively during this conference already, but as we, just to highlight it in a few bullets, number one, acute coronary syndrome due to increased thrombosis, hypercoagulability, and also vulnerability of the increased rupture of vulnerable plaque in these patients. And demand ischemia because of fever and high inflammation in this situation, and microvascular ischemic injury. And the inflammation always the culprit in these cases, causing end-STEMI or cardiogenic shock. It's very rare to see patients, or from our experience at Detroit Medical Center, we were really busy, unfortunately, with COVID cases between from April through May in 2020. Now we see that the surge coming back again, but not as bad. But the majority of patients presenting with NSTEMI, not with STEMI. But when they do, they are really crashing and burning with cardiogenic shock. Low-grade also myocardial inflammation can happen, and localization of COVID-19 within macrophages, but not the cardiocytes. So the drop in, one of the signals I would like to highlight as well is the decrease in the presentation of these patients to the hospital. Patients are not showing with acute coronary syndrome having chest pain or even AC changes, but they don't show up to the hospital till late. And this is, we have entertained that questions in the past. So I utilized Twitter to post this question. As you see the date in April 2nd, as we have noticed a lot of ACS patients not showing up. So 500 plus participants responded to that poll saying that, yes, we see a 50% drop in the ACS patient coming to the hospital, especially with NSTEMI or STEMI. So I took this result of tweet and I submitted to a journal asking them, do you see the same signal or are you aware of this situation? So European Heart Journal kind of asked us to write an editorial about the topic, and we summarize the reasons and in the following. Either majority of patients, which is, I think this is the most number one cause, is a fear of coming to the hospital to get infected, or because of the social distancing, they feel like, okay, we don't want to come to the hospital because we're compromising that law that was implemented by the governor, so we don't want to come to the hospital. Or losing health benefits, because as we know, 20 million jobs has been lost because of COVID-19. And that caused, for sure, loss of benefits, and therefore patients are not coming to the health system as before. Or change in the cardiac pain perception due to neurological involvement of COVID-19. They don't have the same chest pain that typical patient do. Or concern of becoming a burden on family and friends. It's different than Egypt, or I am from Syria, that we don't have a social network as strong as in the U.S. In the U.S. that as strong as in the Middle East, for example. Everybody dependent on other resources, or maybe a niece or maybe a grandson. He might help or she might help or not, especially in Detroit area, which is, we are heavily populated with African American, where a kind of disparity, unfortunately, is very prevalent. Or shortage of media attention to heart disease, because every time you open a window, open social media, TV, radio, everything's talking about COVID-19. There's no increased awareness of heart disease at all. So maybe that's one of the hypotheses why these patients are showing up. And then we pushed a survey across the Michigan area, and then a couple of cath labs outside the Michigan, asking them, what is the do you see the same signal as well? And as you see there's a 46% drop in the cath lab volume in March and April 2020 compared to the same period in 2019. And we published this report, and we got a reply from a European saying, yeah, we see the same. Even in Italy, it drops as 70%. So this is kind of a worrisome sign that these patients are coming, although they are more vulnerable for ACS during COVID pandemic. I think all of us have seen these cases, patients coming with advanced cardiogenic shock. We are seeing more mechanical complication that has been published as well, especially from the New York sites, about VSD that we rarely saw nowadays, but now they are coming back because of the prevalence of COVID causing more ACS and the lack of access, or maybe not coming to the hospital from the patient perspective. And then we put also a publication talking about what are the 10,000 feet summary of all COVID and cardiac manifestation. So we came up, I'm just gonna highlight a few bullets in terms of evaluation of cardiac injury that already extensively and wonderfully done by other speakers during this conference. Is elevation of troponin is, yes, is an indicator for bad news and also associated with bad outcome, but also we have to consider the whole picture together. And in terms of ventricular arrhythmia, atrial fibrillation was the most common in our series, and also VT and VF was followed by that. And in case of shock, ventricular failure and or refractory pulmonary failure, VA and VV ECMO may play a role. As a matter of fact, there is a series published from Chicago area by surgeons who do ECMO routinely on these patients. They have a series of 49 patients presented with COVID-19, and they are really not prematurely, but they have a higher, lower threshold to go for ECMO, and they have a better outcome compared to those who did not. Meaning you are decreasing the inflammation, and you are unloading a lot of from the heart and lung during ECMO. That we started to accommodate that here, but again, ECMO has its own stretching resources and require enough personnel to operate it. And the controversy of ACE inhibitor and ARBs that has been going back and forth, that and the most retrospective analysis suggests no deleterious impact of RAS blockade in patients with COVID-19. And then we looked into, as mentioned earlier, there's an increased risk of pulmonary embolism in these patients. And is it true there's increased risk? And if that's the case, are they having worse outcome? And in this series, we did a meta-analysis looking into these patients, and indeed they do have more tendency to have PE, but luckily, because they are treated properly and not as bad as it should as a normal PE, they don't not associated with heart outcome. The caveat in this meta-analysis, we could not find enough big studies to report, so I would keep that take that findings with a grain of salt. Also, these are the cases we're going to be seeing, I think, more and more now because of COVID-19, where patients are really infected, but they are really not coming to the hospital, but yet they come with ACS. For example, this patient came with a stable angina, had a positive stress test, came to the hospital, then has a stent done, but however, despite a therapeutic ACT, had acute stent thrombosis while the patient on the table on the cath lab before taking him off the lab. And despite multiple attempts to aspiration and using 2B3A inhibitor, the patient unfortunately did not make it because he started thrombose everywhere. And an autopsy, he turned to be a COVID positive. Therefore, we changed our policy now to have everybody tested for any elective procedure that I'm going to speak about shortly. So the management of STEMI and STEMI, I think, was covered already in the conference, but this is just when I show you some publication and guidelines came from SCI and also as ACC, talking about the management of these patients in COVID and ACS. And I would like to share with you our experience as well, what we have done during that pandemic. For example, for these patients who are COVID positive, usually we have a dedicated negative pressure room in the cath lab, and also the personnel that are in charge of these patients really have all the PPE all day long, and are the only team taking care of these patients in that lab all day long to minimize the exposure of more staff as well as the spread, and because they are more familiar with the procedure of PPE and cleaning. In terms of lowering the cath lab exposure as well, we minimize the vendor visitors access and observation, and no students during that period. Again, this is a negative impact on on teaching, but again, at the same time, we don't want to have more exposure and more spread. Research as well, coordinators, as a matter of fact, multiple trials presented at AHA 2 weeks ago. One of them is a soloist for Dr. Deepak, but he told us that he has to stop and terminate the study prematurely because of lack of recruitment and lack of funding, all because of COVID. So COVID not just changing our patient care and our the day-to-day activity, is changing even the science that we're going to have. I'm not sure in 2 years how we're going to be keeping up recruiting for these trials with all this restriction because of COVID. Hopefully the vaccine will help. This is our usual preparation. I think all of us know it. N95, a full face mask, disposable caps and gowns. So again, I'll jump into the management of ACS. This is a routine thing. We standard of care for any guidelines. Patient you started on unfractionated heparin, aspirin, a high dose P2Y12 inhibitor of choice. Usually we have a tendency to go with higher potent agents, and statin and beta blocker. This is a suggested algorithm by the SCI, and this is what we follow in our lab as well. So a patient coming with NSTEMI, which is, I would say, 80 to 90% of the patient that we see in the hospital now, and the COVID or PUI or patient under investigation. So we evaluate the risk. If there are high risk features, which is refractory chest pain, hypotension, heart failure, shock, life sustained VT or VF, then this patient has to go to the lab and do a PCR or CABG. If not, then these cases can be quote unquote cooled off with medical therapy that just mentioned, and then when they are recovered, maybe they can be transferred to the floor and then eventually can be worked up as an outpatient for their NSTEMI. We also minimize the procedure that are done in the cath lab during the pandemic peak by, for example, if the patient needs a balloon pump, recardiocentesis, temporary pacemakers, Swan-Ganz, all done at the bedside, and not to bring the patient down to the lab to, again, to minimize exposure. Intubation also, patient if he's unstable or she's unstable and requiring intubation or high flow of oxygen, then the patient will recommend to intubate the patient before bringing him to the lab, since there will be less personnel at the bedside in the CCU or ICU or on the floor before the patient comes to the lab and exposing a lot. Especially there's a lot of virus spreading with intubation, as studies have shown. So again, in terms of the STEMI, that's a little bit different. So these patients can become more challenging. So again, we follow the same algorithm if they are high risk. For example, anterior location, hypotension, class 3 or 4, cardiogenic shock, life-threatening arrhythmias. And these patients will for sure has to come to the lab. However, if they are low risk, which has been identified like an inferior wall, if they have no arrhythmias, they have no actual chest pain, then maybe TPA has a role here. From the cases that I have been involved in the last year, we already gave TPA once for these patients. The patient was really sick. He was high PEEP, high FiO2, and unfortunately, he wasn't doing well from the COVID status, and he developed STEMI. So we ended up giving him TPA. However, he passed away from respiratory problem. So let me go through a case here just to illustrate a couple of points as well. So this is a 54-man presented with no past medical history, but with chest pain and elevated troponin and SC changes, and he turned to be COVID positive. This is his EKG, again, some ST changes in the inferior lead as well as T-wave inversion in lateral leads. So because of his persistent symptoms, suggestion was brought into the cath lab. He has constantly in chest pain despite being on heparin and nitroglycerin drip. This is the first angiogram. As you see here, there's a circumflex is a big vessel, has a moderate lesion in the proximal, but the LAD is heavy thrombotic burden in the anterior wall and with TIMI 1 or 2 flow. So again, with standard of care, we usually do the wire, the thrombectomy, if the burden of the clot is high, but we have a tendency to use more of 2B3A inhibitor. Our agent of choice here is tirofiban, and Tigrelin can be used as well, or Cangalor, but we have been utilizing more of these agents because of the high burden of the clot and to prevent what I just showed you earlier of having a stent thrombosis on the table in these patients. Again, we perform thrombectomy using penumbra and then balloon angioplasty and stenting, and then IVUSing to make sure all the vessel of the size, and then eventually stenting that is appropriately sized by IVUS. And this is the final result. Again, we continue tirofiban drip 0.15 mics per kg per minute for 10 hours. Again, the recommendation up to 18 hours, but again, this is our discretion and extra precaution, especially in these patients, to make sure we don't have any catastrophe that I just showed you. In terms of the ACE inhibitor, we covered it a lot, covered already in the talk, but again, this is multiple meta-analysis showing that there is no increase of infection in the patient already on ACE inhibitor. There is no worsening of infection or disease in patients who are already on ACE or ARBs in these cases. And then same thing in terms of hydrochloroquine that we initially started to use, and then we, in the last period, I think around June or July, we stopped using it. We published a paper about hydroxychloroquine in these patients, and meta-analysis that showed no benefit. And as a matter of fact, before we published this, we had stopped using hydrochloroquine in these patients, especially with ACS. The second case I would like to present is also, unfortunately, is more dramatic. Is a 56-year-old presented in April. This is when the pandemic was at its peak, with several days of chest pain, shortness of breath, and edema. He has multiple comorbidities, multiple stents in the past, but he was hypotensive, tachycardic, and he had a fever and shortness of breath. So he was treated as PUI, or patient under investigation. So he was tested, but brought to the lab because of his presentation, but with the precaution that this patient need to be prepared, treated as a COVID positive with the proper PPE for the staff. This is EKG, again, it's not the benign EKG, especially in the ADR. For sure, this patient needed to come to the lab because of chest pain, hypotension, so he meets all the high-risk feature that I just presented to you using the algorithm. So started on norepinephrine, brought to the lab. Again, you see the RCA is CTO. There's a stent there, so I'm not sure how old was this CTO, but based on the left shot with the collateral left-right, he is for sure has a CTO that says old. However, unfortunately, you see the circumflexus disease with 90% lesion, hazy, clot there, as well as LAD is completely closed with a stent there. So again, multiple wires has been used, and eventually we had to go through pilot 150 to cross that lesion. That was really tough to go across, most likely because it's a heavy organized clot. Because of his late presentation, most likely he's been having a pain for 1 week or 10 days. So maybe he has been infarcting for a while, and now he's coming with this heavy clot that was hard to manage. Again, this is his map. Cardiac index was 1.2, CPO was 0.23, and PAPI was 0.9. Giving these hemodynamics, we proceeded with Ampella. Again, we're doing angiogram within the Ampella. However, he has severe iliac disease, so this is beyond the scope of the talk. But again, our approach was either to consider alternative exegesis axillary or transcaval, which is not a good case at this point because he's in acute phase, or to do a shock wave and do open the iliac, and that's indeed what we did. We put a shock wave balloon, we opened the right iliac, and from there we opened the wave for the 14 French Impella sheath to put it in and then start working. Again, as I mentioned earlier, microcatheter and pilot 150 was used to cross the lesion, and then from there you see the TeleFlow is maybe 1 with this distal disease, maybe showering clot as we are wiring, and then we did imaging that confirmed the clot, and then start ballooning in that area. Some showering as well distally there, but eventually we got it open with a run-through wire. IVUS confirmed that no more clot was present. We ended up putting a short stent there. There was a gap between 2 stents, most likely was the culprit, and the stent was malapposed, which is, I think, was a nidus for this clot to develop. And eventually the patient fortunately did well. 3 days stay in the hospital with Impella, brought him back. We took away the Impella, and he left with ejection fraction of 40%. Again, but he ended up with a COVID positive test. A lot of work, a lot of exposure to the staff, but again, by having the fact that he is a PUI and properly triaging him through the right routes to go to a negative pressure, only certain people are in the lab treating him. That minimized the exposure, and all the staff was safe. One of the good effort also to kind of understand the STEMI and NSTEMI in COVID patient is a NACME registry, which is a North American COVID-19 STEMI elevation myocardial infarction that was led by Dr. Tim Henry from Cincinnati Christ Hospital. He put phenomenal registry that is, as of speak now, he's still recruiting for that registry to understand. And he presented initial prelim data at the TCT 2020 a few weeks ago. So again, there is a lot of work need to be done. We have to understand the pathology as well as these patients and triage them the right way by having a clinical acumen and understanding the patient presentation. And not everybody should come to the lab unless there is a clear indication to minimize exposure, but more importantly, prevention by having the appropriate medication for these patients and increase awareness for these patients to come to the hospital if they have heart problems to make sure we treat them in timely fashion. With that, I will stop. I'm happy to take any question. Thank you so much.
Thank you, Dr. Shadi, for this illustrative presentation. I have one question. Do you have any recommendation about the procedure regarding vascular access, materials, types of stent? or the usual dealing with like usual patients?
In terms of vascular access in the case I presented, or in general?
In COVID patients.
Okay, radial versus femoral.
Yeah.
Our lab is purely, not purely, I would say 80 to 90% radial. I know there is maybe a concern of being closer to the patient in these patients, but I think I don't have any paper that I came across that this approach will increase infection of the staff. So we continue to do the same thing. Radial is our number one access unless there's a problem there.
Thank you. Any comment from the chairperson, Dr. Sharaf, Dr. Muqarrab? Questions?
Thank you, Dr. Chadi. Very illustrative work, actually. The benefit of this meetings virtual actually is good because we see you now. I am here in Sohag and the Congress in Assiut. And we are very pleased to share experience with you. The point of the disease itself increase the incidence of acute coronary syndrome, and at the same time there is a marked reduction in the acute coronary syndrome patients presented to hospitals. Actually, I want to tell you that we have a survey. Actually, we did in most of the centers of Egypt, and informed us our endemic was in June and July. That's the best time of increase in the cases of COVID-19. Show that 80% of the centers confirmed a reduction in the incidence of acute coronary syndrome. The centers, and at the same time, there is a 70% decrease in the primary BCI for those patients. But I want to know that with the increase in the experience, with the increase in the more knowledge about COVID-19, there is increase again in the rate of primary BCI for COVID-19 patients and primary BCI in general for in your center. Increase in the with more knowledge about the primary BCI, there is the rate of acute coronary syndrome is still reduced. The rate of primary BCI is still reduced than before.
Thank you so much, Dr. Ashraf. To answer your question, compared to April, May, and June and July of this year to now, the number of ACS is went up that presented to the lab. So again, maybe this is counterintuitive. Say, okay, you are saying COVID increased ACS, and they were low presentation during the COVID pandemic, but now the COVID is less, but ACS increasing, and I think it's most likely is because of the fact that patients really truly were afraid to come into the hospital, or they are not aware of these symptoms that are serious enough. Unless because everybody telling them fever, shortness of breath, and cough, otherwise don't come to the hospital. And the patient told us that. And there is a 48-year-old woman who came to us with ACS, and unfortunately left the hospital with EF of 10% in a life vest, all because she has been waiting for 2 weeks with chest pain, but she said, I don't have fever or cough, so I thought maybe I shouldn't come to the hospital. So I think there is some area that we need to work on, and we have been doing some public awareness campaign for these patients through the radio, TV, social media. But at the same time, the link between ACS and COVID still does exist. I just finished, actually, I stepped out from the conference to see a quick patient. They told me his troponin was 200 and went to 4,000. He's COVID positive. I saw him yesterday. NSTEMI, COVID positive, fever, high CPR, CRP. And I told him still continue medical management as long as he has no chest pain or shortness of breath or no chest pain or EKG changes. So I don't want to bring this patient to the lab and increase exposure to the staff. And I know with a limited echo, he has no wall motion abnormality. He has normal ejection fraction. So I thought maybe we can proceed with medical management for now.
Thank you, Dr. Mohammed. Can I ask a question, Mohammed?
Dr. Mohammed. Dr. Islam.
Dr. Islam Bey.
Dr. Shadi, thank you, Dr. Shadi, for this excellent presentation and excellent very nice review about managing patient acute coronary syndrome. Let me take the opportunity to ask you one question about patients with non-anterior myocardial infarction in a country like Egypt, where the facility of primary PCI is not there every time, every place. Can we manage those patients with lytic therapy, like patients with inferior MI, all the morbidly ill patients, etc.?
Absolutely. A very good point. As I showed you in the algorithm for inferior MI for STEMI that are low risk, and one of them is inferior MI, and and even in the US, with more than 120 minutes away from a cath lab, they do lytics in these cohort of patients. So I definitely encourage that as long as the patient not in shock and as long as the patient doesn't have any malignant rhythm, then inferior MI can be managed with lytics.
Okay, thank you.
Dr. Islam.
Yes.
Dr. Islam?
Yes.
In China, in the first 2 months of the epidemic, they prevented the intervention except for those with hemodynamic instability. This was very interesting, actually.
Dr. Sharaf, yes, this is the worst time, not the best time of COVID.
Yes. But I think by now, with more understanding of the problem, nearly the situation changed. We can interfere with even patients with less. We even return to doing the elective cases in Egypt, actually.
Yes, sure.
Thank you, Dr. Shadi, for his.
Dr. Shadi, thank you for attending our meeting. Thank you very much.
Thank you so much. I mean, as I said, this is unfortunately or fortunately one of the advantage of COVID to create a digital platform we can all meet and without travel and develop a new collaboration and network with phenomenal cardiologists like yourself. Thank you so much for having me.
Hope to see you in person in Egypt very soon.
Okay,
yes.
Thank you, Dr. Shadi. Please stay with us. I have the pleasure to invite Dr. Mustafa Muqarrab, Professor of Cardiology at Al-Azhar University. He will speak about COVID-19 and cardiovascular drugs. Dr. Mustafa Bey.
بسم الله الرحمن الرحيم. الصوت واضح؟
It's so clear.
Clear, okay. Assalamu alaikum. First of all thanks for Professor Hussam and organizing committee who give me this opportunity to be part of this successful meeting. My talk about COVID-19 and cardiovascular drugs, I know it's a hot and long topic. I'll try to be fast and I will concentrate on daily drugs used in our daily practice. As we know, severe acute respiratory syndrome, coronavirus COVID-2, which can lead to coronavirus disease, is spreading rapidly all over the world. The disease was declared pandemic by the World Health Organization on 11 March 2020. COVID-19 is caused by severe acute respiratory syndrome, coronavirus COVID-2. This is novel single-strand envelope RNA virus. And 7 strands will known today. I'll skip all this introduction. It's clear by many speakers. But for SARS-CoV-2 infection is caused by binding of viral surface spike protein to the human angiotensin converting enzyme 2. It's very important point. because angiotensin converting enzyme 2 widely spread among different organs in heart, in kidney, in intestinal tract, and in small vessels in endothelium. Patients with underlying cardiovascular disease are increased risk for mortality and morbidity from COVID-19. This infectious disease can affect the cardiovascular system both directly and indirectly. The increased susceptibility of patients with cardiovascular disease with COVID-19 outbreak, the fact that this population is already under treatment with various classes of medication places them at higher risk for adverse drug effect and possible drug-drug interaction. We have a drug-drug interaction and disease affecting myocardium, and myocardial disease can affect the prognosis of COVID-19. Although our current understanding of COVID-19 pathophysiology would suggest increased number of cardiovascular complications during the pandemic, the total number of cardiovascular-related admissions has paradoxically declined by 49% in state, for example. And as Dr. Shadi mentioned before, this paradox may be attributable to fear of contracting COVID-19 and medical symptoms, and those not indicative of reduction of cardiovascular mortality. So we have to pay sufficient heed to the cardiovascular problem of our patients even more than before. It's still the #1 killer globally, even in the COVID-19 era. Now, till now, no approved medications for COVID-19 with general agreement all over the world, but there is increase in number of cardiovascular complications during pandemic. Why cardiovascular disease affected more with COVID-19? As you see here, myocardial affection can done by different mechanisms, either myocardial injury, arrhythmia, myocardial infarction, heart failure, cardiac, due to affection by angiotensin converting enzyme inhibitor, and also by cytokines storm occur during disease course. Now we'll rapidly speak about categories of cardiac diseases and affection or effect of COVID-19 on different drugs used daily in our practice. For acute coronary syndrome, for example, mildly increased cardiac troponin level less than 2 to 3 times the upper limit of normal, particularly in elderly with pre-existing cardiac disease, don't need workup or treatment for type 1 myocardial infarction unless it's suggested by angina symptoms and or echocardiography changes. Minimal elevation in troponin level can be explained by pre-existing cardiac disease or myocardial injury during SARS-CoV-2 infection. And it's dilemma for management, for diagnosis, and for treatment. Consequently, changes in biomarker patients' presentation, past medical history, ECG changes should be considered altogether. Indeed, effort should be concentrated on the differentiation of viral-related cardiac injury from acute coronary syndrome. The limitation for primary coronary intervention, as Dr. Islam mentioned and Dr. Shadi, in this current pandemic era have made pharmacotherapy more crucial role than ever before. During drugs for acute coronary syndrome, as we know, antiplatelet and effective antiplatelet regimen is a matter of utmost importance in acute coronary syndrome management. The optimal antiplatelet regimen hinges on the treatment strategy and the COVID-19 status. The current guidelines, that is fibrinolytic therapy, are to be used in patients not receiving active therapy for COVID-19. The BY12 inhibitor of choice now is clopidogrel, although TICA can be also considered. According to TREAT trial, in all patients undergoing primary percutaneous intervention, prasugrel and ticagrelor are recommended. Whatever case may be, decision-making with regard to patients with COVID-19 should be in a light of drug interaction and disease interaction. You are dealing with very fragile patients. He has a concomitant comorbidities like kidney, like thrombotic events and bleeding events. So we are treating our patients in acute coronary syndrome case by case. Aspirin at low dose administration in acute coronary syndrome has minimal anti-inflammatory effect, so concern regarding the potential hazard of non-steroidal anti-inflammatory drugs on clinical course of COVID aren't applicable to aspirin. The loading and maintenance dose of aspirin for patients with COVID-19 should be the same as those administered to the normal population according to usual guideline. If the patient has coagulopathy, again, clopidogrel is the BY12 inhibitor of choice because it poses lowest bleeding risk. Another concern of the prescription of antiplatelets is the interaction between BY12 inhibitor and protease inhibitors. I mean antiviral drugs. Antiviral drugs is potentially antiviral agents for COVID-19. It can, through the strong inhibition of cytochrome B3A4 pathway, increase the risk of bleeding with ticagrelor. Consequently, ticagrelor is contraindicated in patients receiving such antiviral medication. Although also this antiviral medication can diminish antiplatelet activity of clopidogrel. That's why we must measure antiplatelet function from time to time. In individual without coagulopathy and bleeding risk, prasugrel may be good option with those antiviral drugs. For glycoprotein 2A receptor inhibitor, Dr. Shadi mentioned that if the patient has a large thrombus burden, you can give him glycoprotein 2B3A receptor blocker. The choice one is tirifoban and etifibatide, but avoid abciximab due to thrombocytopenia. Anticoagulants, and there is a relationship between COVID-19 and anticoagulants, either for treatment or for concern about acute coronary syndrome. As low molecular weight heparin may have advantage over the unfractionated heparin in patients with coagulopathy, it may be regarded as the agent of a choice. Still, if the patient is considered at a high risk or severe kidney injury, unfractionated heparin may be preferable because protamine sulfate antidote for unfractionated heparin is there. In patients receiving fibrinolytic therapy, low molecular weight heparin can be used, and it's the agent of choice if the cardiologist prefer angiography. Also, in center where angiography is routinely done within 24 hours, unfractionated heparin still constitutes the best option. If complete revascularization done, okay, this patient's completely revascularized, manage the guideline, and stop anticoagulants unless needed parenteral, unless needed for COVID-19 states. It should be noted that there are no interaction between parenteral antithrombotic agents and currently available COVID-19 medications. And this is the Mount Sinai algorithm for management of COVID patients with anticoagulants. And this is, by the way, the interaction between or interrelation between COVID-19 and cardiovascular drugs. As regard thrombolytic therapy, we are performing till now thrombolytic therapy for our patients in low-risk patients. Rather than anterior STEMI complicated by cardiogenic shock in many centers in Egypt. Reperfusion therapy with thrombolytic is an attractive option in stable patients without contraindication. Tenecteplase, the most fibrin-specific agent, is a drug of choice in patients with COVID-19 on the strength of its high success rate, low bleeding risk, and single-dose administration strategy. Also, tenecteplase is also associated with least fibrin depletion of all fibrinolytic agents. Statin still have a beneficial vascular and myocardial effects that are attributed to their anti-inflammatory effects, which may explain why the continued use of this class of medication in patients with cardiovascular or cardiometabolic indication may have a positive effect in the presence of acute viral respiratory infection. Irrespective of COVID-19 high-intensity statin, atorva or rosuvastatin, should be administered to every patient with acute coronary syndrome. But you have to measure liver enzyme, because some patients develop high liver enzyme with management of COVID-19 and statin application. It's advisable, therefore, to monitor liver function and creatinine kinase level at baseline and periodically thereafter. In the case of severe rhabdomyolysis or increased liver enzyme, it's recommended that statin be temporarily stopped. Another concern is the potential drug interaction between atorvastatin, rosuvastatin, and antiviral medication. The respective daily dose for statin is 20 for atorva and 10 milligram with rosuvastatin. Beta blocker, according to the guideline on acute coronary syndrome, beta selective 1 beta blocker may be preferred over the non-selective agents. Among the beta blocker, selective beta blocker 1, where metoprolol succinate is metabolized by cytochrome B2D6, and bisoprolol is partially metabolized by cytochrome B3,4A and cytochrome B2D6. Atenolol is not metabolized by cytochrome B450. Bradycardia and hydroxychloroquine also has been reported, which may be potentiated with beta blocker. As with patients receiving beta blocker, diligent monitoring of the heart rate and the blood pressure is warranted. Patients with hemodynamic instability shouldn't receive beta blocker unless there are clear improvement in their blood pressure and heart rate after stabilization. Angiotensin converting enzyme, now it's clear angiotensin converting enzyme and ARBs aren't contraindicated in COVID-19 patients. As Dr. Shadi said, all data with continuation of angiotensin converting enzyme and angiotensin receptor blockers. At present, there are many major studies on ACE inhibitor and ARBs in patients with COVID, and they have all reported no harm in use of RAS blockers in patients with COVID-19. But take care, in patients with COVID-19 receiving ACE inhibitor and ARBs, the close monitoring of blood pressure, serum creatinine, and potassium is recommended. Heart failure, I'll skip this theoretical speaking. Beta blocker with exclusion of patients with hemodynamic instability and lung edema, patients with heart failure and COVID-19 must receive beta blocker. Similar to patients with acute coronary syndrome, beta selective 1 preferred over non-selective 1. Antiviral medication can consequently affect the metabolism of all beta blockers because it acts the same on cytochromes, consequently affect metabolism of all these agents, which is why watchful monitoring of the heart rate and the blood pressure of patients receiving antiviral medication. ACE inhibitor and ARBs and ARNI also not contraindicated in cases of COVID-19. The concentration of psychopetrel rises in tandem with administration of antiviral treatment for COVID-19. So you must follow serum creatinine for your patients more periodically than regular following after application of ARNI. For diuretics, there is no specific interaction between loop diuretics and anti-COVID medication. So this drug can be safely initiated or continued in patients with COVID-19. Given the high rate of acute kidney injury among this group of patients, diuretic therapy should be closely monitored in the term of vital signs, serum electrolytes, and creatinine. Mineralocorticoids antagonists, if administered under close surveillance or observation, can also be continued in patients with COVID-19. Concerning patients receiving protease inhibitor antiviral drug, spironolactone preferred rather than ibrellinone in patients on antiviral treatment for COVID-19. No specific interaction is known between thiazide and antiviral treatment, with indapamide being an exception. Antiviral treatment increase the level of indapamide so you can reduce your dose. It's also essential to take care the risk of QT prolongation associated with chloroquine and hydroxychloroquine. As patients with electrolyte disturbance are at great risk, those receiving diuretics should be monitored for potassium and magnesium level. For digoxin, all patients who are on digoxin and hospitalized for COVID-19 should be monitored meticulously because of the possibility of instability during acute infection. This may necessitate the measurement of serum concentration in patients with COVID-19 who continue on receive digoxin. Hydroxychloroquine can also increase the concentration of digoxin through unknown mechanism. So if you give a digoxin with hydroxychloroquine, these patients may develop torsades de bois or QT prolongation. The narrow therapeutic index, drug-drug interaction, and potential for unacceptable serum concentration of digoxin may require physicians to reconsider the continued use of digoxin for patients with COVID-19. Also, hydralazine and nitrates, no contraindication in patients with COVID-19, and most drugs for COVID-19 doesn't affect this medication. For ivabradine, it appears that ivabradine can continue safely in hemodynamically stable patients with COVID-19. The co-administration of potent CYB450 inhibitor can increase the level of ivabradine sixfold. So it's better to avoid to use ivabradine with antiviral medication used for treatment of COVID-19. For myocarditis, Dr. Sameh Shaheen mentioned before, most of these patients is asymptomatic like any viral myocarditis. The pathophysiology of COVID-19 is the same as for myocarditis in that it's detected several days after fever initiation. The underlying mechanism for myocardial injury in patients with COVID-19 is related to upregulation of angiotensin converting enzyme 2 in the cardiovascular system, while a rise in cardiac marker may not be related solely to myocarditis. Elevated level of troponin and brain natriuretic peptide are correlated with worse prognosis. It appears that similar to other instances of viral myocarditis, COVID-19 related myocarditis can exist without clinical symptoms. Based on data extracted from cases with myocarditis as consequence of other viral infection, the treatment of COVID-19 related myocarditis is mostly supported. But we have decompensated patients who developed myocarditis, so antiviral therapy and immunomodulator can be of help that used in treatment of COVID-19 can help patients with myocarditis. The treatment of new onset heart failure with balanced use of vasopressor, inotropes, diuretics, vasodilators, and fluid therapy may be life-saving. Based on latest guidelines on the management of critically ill adults with COVID-19, norepinephrine is the vasopressor of choice, and vasopressin can be added if the target mean arterial blood pressure is not achieved with norepinephrine. The use of dopamine is discouraged because of the increased risk of arrhythmia and mortality. In patients with COVID-19 who suffer cardiac shock, dobutamine is the inotrope of choice, and milrinone can be added in the refractory cases. Corticosteroid may be beneficial in patients with lymphocytic myocarditis, and it's already used in management of COVID-19 patients. This is also true for patients with COVID-19, as systemic corticosteroids are suggested mechanically ventilated patients with ARDS. Arrhythmia, it's an important topic in COVID-19 due to some medications or many medications used for COVID-19 can induce arrhythmia, single or in combination with each other. Cardiac arrhythmia, such as tachyarrhythmia and bradyarrhythmia, are more cardiovascular complications that occur frequently in patients with COVID-19. Cardiac arrhythmia may be attributed to direct myocardial injury or secondary to systemic alteration due to acute viremia, metabolic disorder, hypoxia, neurohormonal changes, and inflammatory stress. Patients with COVID-19 are in hyperinflammatory states, have hypercytokinemia, and arrhythmogenic potential. All cytokines increase, monocyte chemo-attracting protein increase, tumor necrosing factor increase, and all of this are associated with fatal arrhythmia. These cytokines, particularly interleukin 6, prolong QT via their direct effect on the ion channels. And we can use drugs like hydroxychloroquine or azithromycin that increase the possibility of QT prolongation and torsades de bois arrhythmia. Several COVID-19, as we mentioned, can cause this. The risk of drug-induced sudden cardiac death can be augmented if the drugs are used in combination with each other. The largest multinational registry analysis in this regard to date reported that the use of hydroxychloroquine and chloroquine alone or with macrolide was associated with increased risk of de novo or de novo ventricular arrhythmia and mortality in patients with COVID-19. And there is another risk factor for development of drug-induced sudden cardiac death and torsade de bois in patients with COVID-19. This risk increase advanced age, female sex, structural heart disease, congenital lung QT syndrome, electrolyte disturbance, hypokalemia, hypomagnesemia, and hypocalcemia, concomitant use of loop diuretics. So you must follow your patients in every day, every step in management. Hepatic renal failure, baseline QT prolongation, concomitant QT prolonging medication like sedation and others, fever, sepsis, and inflammatory states. I'll skip this, mentioned by my professors and my colleague, but the general advice is to keep your potassium level in patients with COVID-19 above 4.5 milligram per deciliter and magnesium up to 2 milligram and more per deciliter to avoid development of arrhythmia. Another source of concern is the interaction between antiarrhythmic and protease inhibitor antiviral drugs used for treatment of COVID-19. Protease inhibitor can augment the effect of amiodarone, lidocaine, and quinidine. In patients whom administration of mentioned antiarrhythmic is necessary, caution should be exercised through ECG monitoring and dose reduction. Also, the co-administration of protease inhibitor and the class 1C antiarrhythmic medications, flecainide and propafenone, is not recommended. Lastly, if you want to know the drug-drug interaction, you can go for this website. I mean not Muhammad Salah, but Liverpool COVID-19 drug interaction. Just clicking on this link, and you will go there and you see the drug-drug interaction for any drug for COVID-19. You will find this. If you name any drug like this drug or another drug, and drug interaction will be mentioned here immediately, and it's a very nice website. In conclusion, our understanding of COVID-19 still till now is very limited. We have a long way established guidelines for treatment of COVID-19 and related comorbidities, and final case-by-case treatment, patient's risk assessment, and associated disease, still a corner of stone for management. And thank you.
Thank you, Professor Muhammad Muqarrab Mustafa Muqarrab for nice and illustrative lecture. Because we have a short of time, we go to the next lecture by Professor Muhammad Satiha. He will speak about intervention in COVID-19 patient. It is different. Dr. Muhammad Satiha?
You hear me?
Yeah.
Okay.
Are you hearing me?
Yes, I hear you.
Okay. You can start, Dr. Muhammad.
Yes, just a minute. Share.
دكتور خالد شكري. دكتور
السلام عليكم.
وعليكم السلام ورحمة الله. Ready يا دكتور محمد?
I am ready. You see the slides?
Yes.
Not yet.
The slides, you don't see the slides?
Yes, we
slides
see it.
still. Okay.
For me, okay.
Okay, okay. Thank you very much, Dr. Hussam. Welcome, Dr. Islam, and all the panel. I'm very glad to be for the first time in CardioAssiut. My talk will be on interventions in the COVID. Is it different or not? Definitely, it is different, and everyone knows that. I start my slides with just a case presented to us with the possibility of COVID. It's 70 years old diabetic hypertensive patients presented post-cardiac arrest on non-STEMI, very high-risk patients. We went to the cath lab, and you can see the picture here. There's a lot of lesions, a lot of thrombi, and after intervention, this was a case like this, no reflow, thrombus everywhere. It was a catastrophe for the patient. We take a long time for this patient to treat it medically, and we succeed to manage our patient medically. I started with this case to see that in the COVID era, we have a lot of thrombus burden in the vessel. There is also the high risk of mortality, high risk of major in-hospital cardiac events, and also the mortality is much higher in hospital and during the transfer from hospital to hospital. The difference after COVID, it is in three ways. In the patient triage, inside the cath lab, and also in the outcome of intervention. The patient triage and the selection, this is a general rule for every patient with an acute cardiovascular problem. The first will be the emergency room, the access, and you have to put a checklist to assess the probability of COVID infection. If there is a fever, if there is respiratory symptoms, if there is a previous contact with a COVID patient, or there is a family history of COVID infection. If the patient has no COVID, the triage for your patient go through the standard protocols. If there is a possibility of COVID infection and the patient have needing hospitalization for the cardiac condition, if the vital signs are stable, put your patient in a waiting room and complete your viral screening test. If your patient had an unstable clinical situation, put your patients in emergency department for the first care and for screening. If the cardiac condition is not requiring hospital admission, discharge your patient at home for quarantine or consider outpatient management. Very important to know to categorize your invasive cardiac procedures during COVID-19. You should know which procedure you should do immediately and which procedure you do within days and which procedure you do within months and which procedure you should postpone it for more than 3 months, depending on the clinical situation. For example, in ischemic heart disease patient, STEMI patients in emergency, you should don't postpone this patient. You should go for management, and the most important management is still in COVID and before COVID is a primary PCI. This is the treatment of choice. Also for non-STEMI patient acute coronary syndrome in a very high risk and high risk patients, and I will tell you in a few minutes which is very high and which is high risk patient. Also, third, the patient is a cardiac shock. These three categories, you should don't postpone your patient. You should intervene immediately. Urgently should done before your patient within days, within hospitalization. For example, non-STEMI patient in intermediate risk, unstable angina, left main PCI, last remaining vessel for PCI, decompensated ischemic heart failure, angina pectoris class 4, CABG patient with non-STEMI unsuitable for PCI, you should go for CABG within hospitalization. Lower priority procedures, and you should perform this procedure within 3 months, less than 3 months. For example, patient with advanced coronary artery disease with angina class 3 or our NIHA class 3, staged PCI of non-calvary lesion post-STEMI, proximal LAT PCI. And for the last procedure, which is elective procedure, you should do this procedure. You can postpone this procedure for more than 3 months, like CTO intervention, angina class 2 and NIHA class 2 symptoms. For the valvular heart disease, for also procedure should be done immediately. Emergency balloon aortic valvuloplasty at a bridge to TAVI or SAVR in a highly selected decompensated patients. Again, surgery in aortic dissection or cardiovascular trauma, valve repair or replacement for acute failing native or prosthetic valve causing cardiac shock. This is and emergency procedure should be done immediately. The second category of this patient urgently should be done within hospitalization within days. TAVI patient with decompensated aortic stenosis, transmitral edge-to-edge repair in hemodynamically unstable patient with acute mitral regurg who are unsuitable for surgery. Mitral valve surgery with hemodynamically unstable patient with acute ischemic mitral regurg. Mitral regurg, aortic regurg in patients with infective endocarditis is also urgent indications. High risk for embolization after infective endocarditis, patients with atrial myxoma. The third category, which is a lower priority, you can do that within 3 months as TAVI or SAVR in severe aortic stenosis area less than 0.6 with a mean transvalvular gradient more than 60 millimeter mercury in symptomatic patient with on minimal exertion. Second one is a TAVI or SAVR in symptomatic patients with low flow, low gradient aortic stenosis with area less than 1. The gradient is less than 40 in a patient with ejection fraction less than 50%. Or again, mitral valve surgery or transcatheter mitral edge-to-edge repair in patients with mitral regurg with congestive heart failure who cannot be stabilized medically within the 3 months. Also, mechanical
دكتور سطيحة بروفيسور سطيحة.
Seems that there is a problem with the internet at Tanta, maybe. Can we ask him to reconnect again, Dr. Ashraf? Our colleagues from IRIS.
رويدة تعالى بسرعة.
ايريس يا جماعه.
Sorry.
دكتور محمد
نعم.
معانا دلوقتي تمام عشان النت قطع شويه ورجع تاني. You can start.
Yes, I am with you now. Arrhythmic heart disease, and we finished with that. Other interventions, the cardiocentesis and emergency, you should do immediately. Biopsies is a lower priority. Left atrial appendage closure is an elective procedure. BFO, ACD, right heart rate, alcohol ablation, invasive ablation for the right cardiomyopathy. Should we start with our patient with STEMI? What is the change in the STEMI patient with COVID-19? If you have a patient with a STEMI in the STEMI network and the ambulance is ready, transport your patient to the hospital with 24/7 CAS ready for service. And if the patient is in timely primary PCI possible, if yes, do primary PCI. If it does not time primary PCI possible, give fibrinolysis for this patient. Again, for self-presenting patient or patient transported from another hospital, if the, with COVID, patient hospitalized patient with COVID-19, if at hospitals with 24/7 CAS lab, do primary PCI. If at hospital without 24/7 CAS lab, you should transfer your patient for primary PCI if it is a time of primary PCI, or otherwise you do fibrinolysis. What is also important generally, only hospital equipped with, to manage patients with COVID-19 should maintain 24/7 cath lab service for primary PCI. Also, any STEMI patient should be managed assuming that they have positive COVID-19, and also before fibrinolysis, if it is not a speculation about for a STEMI, if you prove that this ST elevation is for ST elevation myocardial infarction. If it's COVID is possible and symptoms also consistent with acute myocardial infarction, do also primary PCI. Otherwise, for a typical presentation, you should do some tests to be sure maybe this patient is in viral myocarditis, or you can do also CT angiography. Again, for the acute patient with STEMI, the change is very important. Even patient has a COVID positive or COVID negative, there should be a universal use of personal equipment, for protective personal equipment to protect the cath lab team, even the patient has no COVID in this period. Again, for this patient, you should prepare also your patient for dedicated cath lab for COVID-19. TCT in 2020, the primary PCR is the preferable approach to treat acute ST segment elevation. Even in COVID, the current or ongoing has been refractory to medical treatment, life-threatening arrhythmias, mechanical complications of acute MI, acute heart failure with acute MI, recurrent intermittent ST elevation. And those patients of high risk, you should intervene immediately for invasive strategy, like STEMI patient. Again, for high-risk patient, which included patients who established diagnosis of non-STEMI, depending on the cardiac troponins, and should include one of the following dynamic STT changes or recurrent symptoms. Those patients go for hospital, for a hospital for a COVID-19 equipped hospitals. For early invasive, it should be done within the first 24 hours. For intermediate risk patients with non-STEMI and associated with diabetic, renal insufficiency, ejection fraction less than 40, congestive heart failure, early post-myocardial infarction, or prior to PCI or CABG. Also, this patient will be hospitalized in a COVID-19 equipped hospitals for non-invasive testing to prove which kind of this patient you are going to intervene. Again, low-risk patients, which in any condition not listed in the other groups, this patient not hospitalized would go for non-invasive testing. For the chronic coronary syndrome in the era of COVID-19, we should continue medical treatment in those patients, follow up those patients through the telehealth is recommended. Revascularization must be postponed in low to intermediate risk patients. Postponing the non-invasive testing for coronary syndrome patient should be also considered. CT angiography should be the preferred to non-invasive functional testing during COVID-19. So CT, as Dr. Ali said, it is recommended, it is more safe to do that. Screening should be considered before cardiac surgery with nasopharyngeal swab or CT scan. Chest revascularization for high risk chronic coronary syndrome patients may be considered during COVID-19. PCI may be considered over CABG in selected patients during COVID-19. Identification of COVID-free hospital may be considered as a hub for cardiac surgery. Also, invasive management of chronic coronary syndrome in COVID era should be deferred until the patient has recovered completely whenever possible in this. It's different also inside the cath lab, for the cath lab team, for the nursing, for the other the physicians, the assistant, contact nurse, also the circulating nurse. You should be wearing all these protective devices, protective equipments to protect ourselves from infection. This is an overload also in cath lab for us. A big change in you work in a situation you cannot. It's not really is not comfortable to do that. Also, everyone should follow the steps, put on personal protective equipment for the patient. This is also explained by Dr. Shadi, and also how to wear off, how to remove this personal protective equipment. This also has a rule. And also for the patient, every patient who enters the cath lab should wear a surgical mask during the procedure. Also, as an example for disinfection protocols during catheterization for the cath lab, for the floor, for the walls, for everything. Also for air condition, you should use a negative pressure air condition system. Is recommended when COVID positive patient is on the table. Also, in the era of COVID, the outcome of treatment for acute coronary syndrome is also different. There is a decrease overall number of primary PCI, as we said. The longer symptoms to hospital time in acute coronary syndrome in the COVID era. Also, the increased outcome, adverse outcome, especially during hospital transfer, is almost about 75% from mortality in the first few hours occurred during hospital transfer and before the patient came to the cath lab. This is a diagram showing how much lowering the number of primary PCI after lockdown in the COVID era 19, and also again for the COVID the time from symptoms to hospital and from door to balloon during intervention also delayed after onset of COVID-19. Also the hospital mortality and the major cardiac events also increased, especially in hospital outcome is increased, but after that it is almost equal. Here is very important to see that PCI for STEMI is 27% has been reduced or stopped. For PCI for non-STEMI, almost 38% reduced or stopped. For unstable angina, about almost 53%. For post-cardiac arrest, PCI reduced by 31%. And look for the elective procedures for PCI for coronary syndrome, about 90% stopped or reduced. Diagnostic elective cardiac catheterization, 95%. TAVI, almost 90% reduction. Transcatheter mitral repair, almost 90%. Other structural intervention, also 90% reduced in the COVID era. I reduced or stopped. Here, the impact of COVID on pandemic management of acute coronary syndrome, coronary angiography reduced by 27%. Delay to reperfusion in the COVID era by 48%. Fibrinolysis administered in more than 22% more application of fibrinolysis. Cardiac shock and mechanical complication increased by almost 30%. The restriction to the indication for intensive care also by 40%. Reduction in cardiac rhythm monitoring almost about 20%. For non-STEMI patient, angiography and the PCI had reduced by almost 40%. Increased delay for early invasive by almost 60% reduction. Also the reduction in cardiac rhythm monitoring about 25%. All acute coronary syndrome reduced in hospitalization and the referral almost in 90% of the case. Look here for this one, for STEMI management before in 2019 and 2020, there's a significant reduction, about 30% reduction in the number of procedures in STEMI, 39% in the number of after non-STEMI, unstable angina, coronary syndrome. Here, your time, the symptoms onset to first medical contact per minute increased from 71 a minute to 105 minutes increase. This is a significantly higher number of minutes increased to first medical contact of the patient with COVID. Again, for a simple onset to reperfusion also increased from 200 minutes to 233 minutes. Again, the mortality in hospital mortality outcomes in patients confirmed with STEMI, mortality also increased from 5% to 7.5%. Is also significant. Platelet and platelet therapy, as Dr. Mustafa said, but there is some exchange. That's why if you look to the mechanism for viral infection, start with viral membrane interaction, viral replication, viral dissemination, and after that, you get the endothelial dysfunction, platelet activation, neutrophil platelet aggregation, neutrophil migration, and fibrin thrombus formation. It is the best time to apply for antiplatelet therapy and double antiplatelet therapy. This number is the thrombus formation. After that, you have a diffuse alveolar damage. You have platelet consumption. You have thrombocytopenia at that time. And so that the complication from double antiplatelet therapy is higher in this situation. And just some people, they say that you should reduce the duration of double antiplatelet therapy after post-PCI in COVID patient to maximum 3 months. After that, single antiplatelet, it's going to be maybe B2 Y12 inhibitors. And also the ticagrelor may be better because it had a potent anti-inflammatory effect, and in COVID era, because most of the complications have from severe inflammation in this patient. Also, you have a risk after in this stage, that risk of disseminated intravascular coagulation and diffuse alveolar hemorrhage. So you have to reduce, and that's why you have to reduce the number of the drugs which can increase the number of hemorrhage. In conclusion, ladies and gentlemen, the interventional cardiology practice has been definitely changed in multiple aspects by the COVID-19 pandemic. The cath lab personnel availability is reduced. The need for protective equipment, the management of acute coronary syndrome patients, the massive reduction in procedural activity. COVID-19 pandemic has deeply affected interventional cardiology practice. And thank you very much for your attention.
Thank you, Dr. Muhammad.
Thank you, Dr. Sateha, for this excellent talk. We come back to the case. Dr. Tariq will give us the final wrap-up.
Thank you. Thank you all. Now back to the case again. I will discuss how we managed the case actually, and I hope that the panelists are with us. And Dr. Shadi, are you still with us? Because we would like your input into this case. Maybe he has left us already. Okay, how we managed the case. Let's start with case 1. The case 1 was an acute coronary syndrome in an active COVID state, while case 2 is in a post-COVID state, or a patient close to the convalescence state. So starting with case 1, Dr. Sameh Shaheen has elaborated on the Egyptian position statement. And according to the Egyptian position statement algorithm, our case lies in this category, which is a patient who has a high-risk STEMI. The patient was admitted with a cardiac arrest, resuscitation, and so we adopted a primary PCI strategy for this patient, especially that we are in a primary PCI facilitated center. Of course, the PPE guidelines are closely adopted by the infection control sector in our hospital. So we adopted the measures, and the patient in the cath lab was underwent angiography of the right coronary artery, first showing patent right coronary artery. And then the left system shows a dominant CX and approximately totally occluded, highly thrombotic LAD lesion. The decision was to proceed with PCI. After wire passage, we regained flow into the LAD. High thrombus burden still is existing. Then direct stenting was adopted. Stent optimization, and then we adopted also the stent boost technique to make sure that the stent is well deployed. And this is the final result. TIMI 3 flow in the LAD, and the patient was successfully reperfused. So this was a successful primary PCI to LAD, one drug-eluting stent. Patient was extubated successfully and was discharged home thereafter. Now the first question is, what about the long-term antiplatelet management for this patient? Is it different in the COVID-19 patient from the standard of care? The second question, should we adopt other precautions other than the standard of care for STEMI patients, I mean the other drugs? This was answered by the presentations that was given in the context of this session. So the long-term antiplatelet management should not be different from the standard of care and from the recent guidelines of the NSTEMI. So this patient should receive the potent antiplatelet regimen that should be reasonable for this case. And regarding the other medications, apart from the precautions that was mentioned by Dr. Mustafa Mukharrab, all the cardiovascular medications also should be given liberally to such patients, and they should not be declined from the standard of care. We stop here, and maybe the chairpersons would like to put some things into...
Let's have a comment, please.
Yes, please.
You have your
before proceeding to the next case. So if, yes, please.
No, I think your patient is a very good example for the high thrombus burden, that's acute MR. And it looks that if you do thrombus suction, sometimes you don't see any lesion in the vessel. Is it possible that you can also use thrombus aspiration, thrombectomy, and maybe this patient does not need a stent, or what do you think?
Well, in our center, we use the thrombus aspiration as a bailout strategy. So whenever we find a high thrombus burden that retains after using the tools of balloon dilatation and stenting, then we may use it. We tended to down grade our use for the thrombectomy catheters, especially after the latest guidelines downgraded their indication and their recommendation. But of course, it would be a nice choice, especially that this patient had a high thrombus burden. But for me, I would use it only as a bailout strategy.
I mean,
what about the rest of?
Yes, I mean, sometimes after passing the wire, sometimes you appreciate that there is no plaque, no much plaque in the vessel. It's almost all are thrombus. In this case, I always do thrombus aspiration first, just to sometimes I have many patients that only do a thrombus aspiration. The patient went very well. That's why I have to look for the lesion for that. Is a much plaque burden in the lesion or not? Besides the thrombus, of course. You did the best job, of course, but I'm just thinking maybe in this era, if you see the other vessels looks beautifully, it looks no atherosclerotic plaques, it looks in the other vessels. So most probably this lesion mostly are thrombotic lesion, and you can manage it with thrombus aspiration. That's why I'm thinking.
We're happy if we hear the opinion of Dr. Shadi. He is us now. Usually you do a thrombus aspiration for such patient, and then you decide to stent or not, or you go directly to stenting.
Yeah, thank you for the question.
Dr. Shadi, have you seen the angiograms? Should we go through it again, maybe?
No, I didn't see. No, sorry.
Okay.
Unfortunately, I had to skip
Can
out,
I have the slides? We can show Dr. Shadi the angiogram again for this patient. Okay. So. Okay, so this was the baseline angiogram for this patient. This is the right coronary, and this is the right coronary was okay. The dominant left system with
total LAD.
Total occluded LAD and highly thrombotic lesion.
Right.
So I'll give it again. Okay.
Yeah, I see it there. It's a heavy clot.
Okay.
Timmy zero flow.
Okay.
Completely occluded.
Yes. So we passed the wire, and we did just the direct stenting. And here in the iliocranial, you can appreciate that it's very proximal LAD lesion, very highly thrombotic burden, thrombus grade 4 to 5. And then we underwent direct stenting, especially that we had a good visualization of the distal landing.
Maybe.
And this is the final result after doing the stent boost and checking the apposition of the stent and the proper deployment. And it was a 3.5 by 32 millimeter drug-eluting stent. So the questions that we offered Dr. Shadi was that, do we have any changes in the recommendation for long-term antiplatelet management in such patients? I mean, should we adopt the potent standard antiplatelet regimens according to the NSTEMI guidelines, or should we take care that this patient might have some sort of coagulopathy associated with COVID and may have some bleeding risk or so? And the second question was that, should we adopt other precautions regarding the standard of care treatment for such patients? What's your opinion, Dr. Shadi?
For the first question, definitely the longer the better. This is an ACS. As long as the patient tolerates the medication, P2Y12 inhibitor and aspirin, I would keep him as long as possible. It's a heavy clot, it's a plaque rupture, and as long as he has no risk of bleeding. Again, if we want to go with if he fits any kidney dialysis or anemia or history of to require anticoagulation, then that's a different case. If none of these risk factor, then I think I'll keep him as long as possible.
What about if he necessitated to have an anticoagulation for some reason or so? You know that those patients sometimes develop some sort of high thrombus lesion somewhere, thrombotic episodes. So what do you think?
Yeah, or if he fever something, yeah, absolutely 6 months then. Do an antiplatelet for 6 months, and after 6 months you can de-escalate down to one agent.
Okay.
But in terms of the thrombus, I hear the question about thrombectomy versus no thrombectomy.
Yes.
We don't do routine thrombectomy because, as we know, it's level 3 in the guidelines. But the reason why I show the case with thrombectomy because we wired We ballooned and we still see a clot, and we struggle to pass the wire. So this is a kind of required debulking to take this clot out. That's why we did the aspiration catheter. But routinely, we do the same as your approach. If you press the wire, you do balloon angioplasty, you improve the flow, you go direct stenting. One thing I might do extra is IVUS to make sure I image the vessel. I see what is the clot and where is the plaque, and also to help resizing the vessel.
Okay, so if you had to choose between doing an IVUS and doing a thrombectomy, I think you would go for doing an IVUS. Intracoronary imaging is very important. Is that
IVUS.
correct? Yeah.
Yes,
Okay.
absolutely.
So we move to the management of the second case, because the second case is a different case. It's approaching a patient who has
Dr.
been...
Tariq.
Yes.
أنا شرف.
أيوة دكتور شرف تفضل.
Tariq, actually what you did is I see from the doctor view is the best thing, because you need to shortest your procedure time as much as you can. So direct stenting without pre-dilatation, without thrombectomy, and reducing the time of contact with the patient actually is the best. And the patient actually myocardial infarction, so the antiplatelet therapy will continue for 1 year, whatever you bought a stent or not. So I think you did the right thing.
Agree, Dr. Sharaf. The time management is very important in such patients to reduce the time of contact with the patient. That's true.
Hit and run procedures is important in COVID-19.
Absolutely right. Absolutely right. Yes. So we move to the next case, please, the presentation. Okay. The second case was an ACS in a post-COVID state, not an acute COVID state like the previous. So the patient, the ECG, the cardiac enzymes, the echocardiographic findings, all went to a decision of coronary angiography. And the coronary angiography actually showed a dominant RCA with no significant obstructions. And the left system, if you can just take a good look at the distal LAD in the caudal view, you can appreciate that there is some sort of distal embolus, distal thrombus. So this made us to have a closer look. Is it a thrombus in situ, distal, or is it migrated from somewhere else? So taking further views like the spider view, you can appreciate that there is some sort of thrombus in the left main artery, and it seems not subtending a significant ruptured plaque. Of course, this necessitates to be confirmed by intracoronary imaging, which was not available at this time because of some logistic constraints. But we can appreciate that there is distal embolization in the LAD and suspicion, highly suspicious thrombus in the ostium of the left main. Here in the iliocranial view, we can still see this.
For this patient, can you review his ECG before this had ST elevation everywhere,
Yeah,
inferior and anterior?
the ECG, we showed the ECG, Dr. Islam, and it showed...
This is bancarditis more than thrombotic region.
Well, maybe we can wait till the end, and I think you will change your mind after you see the rest of the case.
Sure.
So, okay. So we went for coronary angiography because the ECG, the enzymes, the echo all showed changes that were suggestive of an acute myocardial infarction. And especially that this patient was 2 weeks post-COVID. Although he didn't have a second sample to show that he is COVID-free or negative, yet we thought that this patient would deserve a coronary angiography to see what's going on. And this was what we were confronted with. Thrombus in the left main dislodging distal into the LAD. The troponin was 12 actually in this patient, was very high, yes. So,
glycoprotein 2B3A, and then I second look after 48 hours, something.
Okay.
Dr. Shadi, what's your opinion in that point?
Well, this is very clearly, the vessels that Dr. Tariq showed us is very healthy vessel. I don't see any plaque or atherosclerosis. So it sounds like it's an embolic event. I would do, I don't want to push that left main thrombus anywhere else. What I will do maybe start marinate this patient with 2B3A inhibitor and bring him back in 1 or 2 days to see if these are gone. But I wouldn't even go chase that with a balloon with anything.
The presentation, please. Yeah, thank you, Dr. Shadi. Well, actually, should we?
There is other opinion in panelist. Dr. Magdi, تفضل.
My question to Dr. Shadi and Dr. Tariq, is this thrombus in the left main behind the ECG changes? Yes. ST elevation in inferior and anterior leads?
Well, sometimes, Dr. Islam, we find that when the lesion is in the very distal LAD, especially if it's a big wraparound LAD, it sometimes gives changes and ECG changes in the inferior wall. We see it not often, but sometimes we see it, and we don't have it.
Yeah. Change is ST depression, not elevation, Dr. Tariq.
No, this was an elevation in the inferior leads.
Elevation everywhere. Yeah.
Yes.
Dr. Islam, it might be beneficial to follow up the ECG of this patient. True. Because patients with pericarditis, after a while, the ST segment shows normal ECG. Apart from patients with MI should have a depression of the T segment or Q waves.
I think so. Let us finish Tariq and then we can. Yeah.
Okay, so shall I proceed? Okay, the presentation, please. Back to the presentation. Can I have the slides, please? Okay. Okay, Dr. Magdi from the floor has a comment.
If I have the facilities to do thrombus aspiration, I will do two things for this patient. Firstly, I will do thrombus aspiration. Whether or not I have thrombus aspiration catheters, even by the guiding catheter, the guiding catheter itself touches the thrombus in this view. So I can aspirate the thrombus, and I did it before. If you remember the first case of our primary PCI 6 years ago, I think we aspirate from the guiding catheter. It was in the left circumflex, if you remember.
Yes.
We both worked together at that case. Yes. So I think we have to do aspiration first, and if I have IVUS, I would check the continuity of the left main vessel wall, if there is rupture or not. If there is rupture, so this is a black rupture, and if there is no rupture, so mostly this is embolization, as Dr. Shadi said, or if I have OCT, but OCT is difficult in the left main.
Yes,
it's very
that's the point. The point is that you are facing a situation where further instrumentations would sometimes make the things worse, and conservation at this stage maybe, and medications like Dr. Shadi has said, might be even better choice. So, is intracoronary imaging an option in such case? Yes, of course it would help us to differentiate. Is it a disrupted plaque, or is it a state of in situ thrombosis caused by a hypercoagulable state? Well, patient was maintained on DAPT, aspirin. This is what happened with the patient. He was maintained on DAPT, aspirin, and ticagrelor. He was given intravenous GP2B3A inhibitors in the standard doses. Actually, we tried to convince him to take a second look at the coronaries to assess the thrombi and how the state is, but the patient refused. So the patient actually later underwent a cardiac MRI. We all know that the cardiac MRI has a very important role in the era of the COVID, and talking a lot about the non-obstructive coronaries and the COVID together. So the combination of intravascular imaging and myocardial imaging with a CMR represented a good choice at that time. So the patient underwent a CMR, and I invite Dr. Amr al-Badri, our CMR expert, to present his input on this CMR study. Please, Dr. Amr, join us. We have a dedicated CMR cath lab, CMR lab, I mean. It is dedicated to do cardiac MRI studies, and it is one of the few dedicated labs in Upper Egypt. Please, Doctor.
ده شو بقى ده شو يا جماعة ده.
I'll go by the order of the slides. So these images are what we call, can these run or are these? Okay, so the previous ones were black blood images in the coronal and sagittal planes. And I think Dr. Tariq has put them because they showed like pulmonary infiltrates on both lung fields. So this was incidentally discovered, but these are usually what we start with, the cine images. So we obtain cine images in the same orientations as the echocardiographic views, 4-chamber, 2-chamber, 3-chamber, and short axis. The other views, can we make them run? Okay. So they are not all running, but if we are able to examine the apical most segments, the apical inferior view particularly is almost akinetic, and the other wall motion is more or less normal. It's very subtle. Maybe we can observe it in the three-chamber apical three-chamber and short axis views. But then comparing with these findings, there is a very tiny or small focal transmural area of enhancement in the apical, again in the apical inferior wall. Can I use is there a laser pointer? So in this area, there is a transmural enhancement in the apical inferior wall, again apparent, yes, again apparent in the apical inferior, apical two-chamber view, and amidst the enhancement there is a zone of microvascular obstruction, which shows as a black area within the scar itself. Again, we use multiple views to make sure this is a genuine scar and not an artifact. So overall, this was a scar consistent with the apical, with the LED thrombus that we have seen.
Okay, so this is what we were confronted with in the CMR. So Dr. Islam, are you now convinced still that this is a case of myocarditis?
No, at all. It's left main. It's not an LED. How about the L6? How about the lateral loop?
Okay. So this is the beneficial of multimodality imaging. This is the benefit of multimodality imaging, multi-investigatory tools to be used.
No. My question is the left main supplying the LAD, the apex and the infraopical segment? Or you mean there is a dislodgement of some of the thrombus into the distal LAD?
Exactly. That's what I meant. The thrombus in the left main was non-obstructive, but what was the obstructive was actually the embolization to the distal left main. To the distal LAD, I mean.
Agreed.
Okay, Dr. Islam. So what I want to highlight is that there is still no established consensus on how to handle the ACS patients in the post-convalescent state of the COVID. I mean, do patients pertain a state of chronic inflammation that remains for some time? And accordingly, as was highlighted in the different presentations, those patients should be managed whether they are in the acute COVID state or in the post-COVID state with still with precautions. Is it a state of post-COVID systemic inflammatory response syndrome? Could we put it in this context? We have seen talking about systemic inflammatory response syndrome associated with structural interventions, but is it also applicable to post-COVID states? In this editorial by Professor Libby and Professor Thomas Luscher, they stated that COVID-19 is in the end an endothelial disease. So it carries cytotoxic effects or cytodestructive effects. The SARS-CoV virus has a procoagulant, pro-aggregatory effect on the cells, anti-fibrinolytic effect, pro-inflammatory effect. And after the successful results of the COLCOT trial that has investigated the role of colchicine among patients with MI, revealing that giving colchicine as an anti-inflammatory medication in such patients had a benefit. Could this be applicable also to patients with COVID-19? This is being explored further by Professor Tardif from the Montreal Heart Institute in the upcoming COL-Corona study. This is a phase 3 study that we are awaiting its results by the end of this year. So what to do next in such patient? Should we do an investigation for thrombophilia disorders? Should we investigate factor V Leiden, hyperhomocystinemia, etc.? Or should we manage this just as a case of post-COVID hypercoagulable state and accept that this patient should receive anti-thrombotic medications, whatever the regimen that we are going to deal with? And what about the antithrombotic regimen? Is this patient entitled for dual antiplatelet only, or should he have triple antithrombotic therapy or dual antithrombotic therapy? This is also a kind of debate and is a question to arise. This is the end of my talk. Thank you, and I'm looking forward to your input. Dr. Shadi, are you still with us? Okay. So, Dr. Islam.
I have one comment. If the thrombus is very proximal like this, and very big like this, I think thrombus aspiration will be harmful. If you want to do suction for such thrombus, you should use exciser laser or something else. But thrombus aspiration, you have to have a space to put it distal to the thrombus, not in such thrombus.
Exactly. Okay, any questions from the panelists from the floor? Dr. Islam, Dr. Sharaf?
If I had a last comment before closing this, I don't remember actually which last time I do attend a session for 3 hours in my life. This is maybe because I never attend such an excellent session with an excellent speakers from everywhere in the world. Now we are watching. Thank you, Dr. Hussam. Thank you, all members of the cardiology department at ASIUT. Dr. Amr, Dr. Muhammad Karim, Dr. Abu Al-Qasim, Dr. Tariq Kifafi, everybody, thank you for this superb meeting. I don't remember really 3 hours attending such a superb meeting. Thank you, Dr. Shadi, for your excellent presentation and your excellent input. Thank you, Dr. Ali Ahmed, Dr. Muhammad Satiha, Dr. Mustafa Muqarrab, Dr. Tariq, Dr. Shuru. Thank you, everybody, for this superb meeting. Congratulations, and see you in the next year.
Thank you, دكتور إسلام. بفكرك بس ورانا مناقشة بعد ساعتين.
The whole day is for ASIUT today.
Yes. Thank you, Professor Islam. We are very happy to be with us, and Dr. Sharaf, and also Dr. Mustafa Muqarrab, and Dr. Shadi. Very nice lecture and very nice time. I think I am very beneficial for the all. We thank all, and we see you next time in ASIUT, and thank for all. Thank you.
Thank you.